morning, everybody. I would like to welcome all the viewers in Best Interventional Cases 2020 on behalf of Translumina. So, the topic of today's session is chronic total occlusion, the right tips and tricks. And we have with us our moderator, Dr. Arun Kalyan Sundaram. He is the director, CHIP CTO Interventions from ProMed Hospital, Chennai.
Hey guys, I'd like to thank Translumina for this opportunity and for actually really putting together BIC. I would like to also introduce the co-chairpersons, Dr. Pratap Kumar, who is the Chief Interventional Cardiologist, Chairman and MD of Mediterranean Group of Hospitals, Dr. Rustam Datta from Brisbane, who is an interventional cardiologist and he specialized in CHIP, Dr. Sudhir Rator, Chief Interventional Cardiologist in the UK, and the panelist, Dr. Prabhakar Shetty, who is from Columbia Asia Hospital. He's a senior interventional cardiologist there. Dr. Deepa Kapila, senior interventional cardiologist at Fortis, Escorts Amritsar, Dr. Bansal from Metro Heart Institute, Faridabad, and Dr. Anjan Setia, who is trying to log in because of the cyclone. There's some storm, there's an issue here. But he's a senior interventional cardiologist at BM Birla Hospital in Kolkata. And I guess we move on to the presentations right now. Guys, can you see me? Are we good? Shall we start the presentations?
Yes, good to go, Arun. Yes, please start.
All right, good, lovely. All right. So we have this ambitious goal of how to achieve CTO mastery. I got 10 minutes to do this, so I'm going to kind of whiz through a couple of things. Can you see the screen?
You have to share your screen.
Okay, let us see. Share screen. Okay, there we go.
There it goes. Yeah.
Let me know if you do.
Yes, good.
Lovely.
It's good now.
All right. So that's my disclosures. There's a clear pathway if you really do want to achieve CTO mastery. And I think initially you got to really understand why you select cases. It's also important to select your cases judiciously initially. You got to commit to being a CTO operator. And there are a lot of patients out there that are not getting treated. About a third of patients have residual symptoms post-PCI or CABG, and about 1 in 4 do have residual ischemia. And we tend to ignore the number of patients that we don't work on. We do know that a lot of cases can be done successfully with antegrade wire escalation. However, these are the easier JCTO scores, the lower ones. And if you start going into the JCTO 4s and 5s, you'll see that antegrade wire escalation doesn't work very well. What really works are the other techniques such as ADR and retrograde approaches. So just 2 angiograms here. A lot of us would choose to treat the patient on the right who has a pretty simple anatomy with PCI. On the other hand, you're going to just put the patient on medications when the CTOs are more complex. What I really want to emphasize is before you aspire to be a CTO master, really make sure that your decision making is patient-centered. So anatomy shouldn't tell you if you should do a PCI or not. What should tell you is, would the patient benefit from revascularization? And the second aspect is, do you have the skill sets and infrastructure to take care of it? And if not, make sure you refer to an appropriate person. So how do you get there? What are the skill sets you need? You need to be good in all 4 techniques: antegrade wire escalation, ADR, retrograde, and reverse cart. And also think about how efficiently you get the process done. Learn how to delegate responsibilities. No man is an island. You need to know that your team has to be empowered, your associate, your nurses, your technicians. You got to monitor. Someone has to take care of the ACT, the radiation, what kind of equipment you're using, and if things are happening fairly well, all right? So the other aspect is before you embark on CTOs, you got to be really good with what we generally consider complex PCI, not just you, your nurses, your technicians. Imaging, you got to really know what you're doing. You got to be very comfortable with lesion modification, whether it's IVL, OPN, rota, laser, whatever it is. You got to know how to handle hemodynamics, when to use impeller, left mains, whatnot. And there are lots of avenues out there, even in today's day and age. There are meetings, there's proctoring, there's online education, workshops, like what's going on, and knowing when to have the patient virtually be proctored by another doctor. Save the date, July 9th, we are doing a charity event for COVID. It's going to be 12 hours of CTO extravaganza. So if possible, please do log in. These are some of the patients where are proctored. And why does proctoring work? We do know that in the pre-CTO era, most of the cases were done by antegrade wire escalation as shown by the blue bar. And post-proctoring, you find that even the people that are getting proctored are more comfortable with retrograde approaches and with ADR. Cases are probably the best measure of how far you've come. What kind of cases are you doing? So make sure you periodically measure the kind of cases, the complexity, etc., of what you're doing. And every case, take it as a learning experience, whether you succeed or fail, that really shouldn't matter. And I'm just going to show a few cases. So here is a case that we did as a live case in 2019. It's an RCA CTO. The prior reason for failure was they couldn't deal with the proximal cap. And long lesion, distal caps at a bifurcation. The collaterals are okay. Proximal cap is discrete, and like I said, the prior reason for failure was the calcium. So have a plan before you get in. So I kind of whizzed through this, won't have time to go through the details of each case, but long story short, antegrade gear could not be advanced despite good backup. You can see the Amplatz guide and a guide extension catheter, and it's backing up. So a quick decision to rotate the subintimal space over a shortened wire. Once this was done, we could go fairly fast. Finish the antegrade work, cross the collateral, and once this was done, it was fairly straightforward guide extension reverse card. As you can see, that's the guide extension here. You can see a retrograde knuckle, and you can see the retrograde wire being used to enter the antegrade system. So once this is done, you got to externalize and still optimize the PCI using imaging. That's an IVAS catheter down there, because it was very, very close to a bifurcation, if not at the bifurcation. And this is the final result. And took a total from stick to end about 2.5 hours. This is a case, again, from a live case from IJCTO last year in Lucknow, where I had the distinct pleasure of working with one of the Japanese experts. I'm going to just let this play for a second. It's a CERT CTO, more than 20. Distal caps possibly okay, close to a bifurcation. The collaterals were not very promising, and it was an ambiguous proximal cap. So again, have a plan. IVAS guided entry, which also needed a dual lumen catheter for penetration. There you can see the wire in the proximal cap. That's that bright dot that you see there. So once this was done, lots and lots of attempts with wire escalation, unfortunately it didn't work. Collaterals could not be engaged. So finally, the decision was made to knuckle. So you can see the timestamp is 12:26. So once the knuckle was done, you could see that we were in the architecture of the vessel. So here you see the Stingray balloon catheter, which is the 2 dots over a Miracle 12 that's being advanced to the segment where you need to re-enter. That's the Stingray balloon in position. You can see it in 2 different projections here. And that's a stick and drive. So once this was done, this was exchanged for a workhorse wire. The other branch was also secured with the dual lumen catheter. We confirmed on IVAS that we got both segments, both branches, and we were intraluminal there. And that's the final result. So I'm going to just skim through the third case. This was a case in Chennai again last year. So you guys saw one retrograde that was pretty straightforward, one ADR, and this is also a retrograde. It's a circumflex vessel, CTO, not particularly long. Distal vessel was okay, collaterals were not very great, and a proximal ambiguous cap. Quickly, antegrade options failed because we could not get an IVS catheter and penetrate. So had to navigate that epicardial, but this is where you can get to. So once the epicardial was wired, it was not yet over. That's a microcatheter, and you see that the angle is really bad. So there's some Carlino done. Retrograde wire didn't work. Retrograde knuckle didn't work. And now you're really in a pickle. But with the Carlino, we're able to guide a wire antegrade. There's more Carlino done, as you can see with all the staining here. And then an antegrade wire was done to retrograde, guide the retrograde wiring. And then I used the retrograde wire as a marker to guide the antegrade wire into the true lumen. Essentially, that was a kissing wire technique. Then this was exchange for a workhorse wire. And then the main circ was wired using a dual lumen catheter. And the rest was straightforward, balloon angioplasty, and that's the final result. So really what I want to tell you is that this is kind of the summary slide. You got to decide, there are two aspects to it, right? One, make sure all your cases are appropriate. Make sure that patient decision-making is key and paramount. So know what to do, know what not to do, and when to refer. And then you have to have a very honest conversation with yourself. Are you an aggressive PCI operator? Have you gone through the training? Are you comfortable doing what is generally considered complex angioplasty, the routine stuff? Are you able to learn? And are you okay with failure and complications? And that'll be the end of that talk. Thank you. Feel free to contact me if you do have any questions. Okay, I got to stop share.
Was great presentation, Arun. Yes, clearly I agree with everything you said, that you have to make a decision. Making is very important in terms of selecting right cases, selecting cases which in line with your expertise. And obviously, slowly you have to build up your expertise skill and work out. There are a lot of algorithms now and data available to categorize, like you said, JCTO score, success rate, what technique to start, and has to be efficient, and you should keep moving forward to achieve the goal. Any moderators, anybody, co-chairs, anybody have any brief questions before we move on to the next presentation? Dr. Kapila, Dr. Seth?
I think it was a nice presentation and a brief summary of how CTO should be approached. And I think having hardware with you is equally important, not just going ahead with things. So having the right kind of hardware and willing to change during your procedure. You can change it from antegrade to retrograde quite quickly. Could have a helping hand who's also in know of things. All these things are pretty important going ahead with the CTO. Nice presentation.
Arun, it was a nice presentation. It was actually the most important point. People should understand that CTO can fail and failure to be accepted. Technically, you should be accomplished. What are these 2 points to be very, very clearly to be understood for everybody? I think if the time there is no time permits, we can go to the next presentation. Otherwise,
I agree. Would like to invite Dr. S.S. Bansal now for giving the talk on interesting approach to handling a complex CTO.
Yes, Dr. Bansal, go ahead.
Dr. Bansal, are you with us? Dr. Bansal?
Dr. Bansal, please unmute, sir. You are on mute.
You can screen.
Is it?
Yep, he's unmuted now.
Am I audible?
I Marla this time.
Yes.
Yes, sir, you are audible.
Yes, Dr. Bansal, we can hear you.
चालेल आणखी मला 3 टॉक्स आहेत म्हणजे 10 मिनिटाचे आहेत ना ते.
Please share your screen.
That's right. Okay, am I audible?
Yes.
Okay, fine.
Please go ahead.
सचिन मुखेदकर का नंबर बट वो कर रही हूँ ना पेज तो अजीब सा आ रहा है ये बट बोलियो ना लाइन में
So that is what but ultimately, by using certain tips and tricks, I could successfully go pass through the enter into the true lumen and could do the case successfully. My patient was a 50-year-old Iraqi male who presented after failed attempted PTC of RCA CTO with symptoms of effort angina class 3, dyspnea class 3, and he had old anteroseptal MI, LAD was infarcted and non-viable, RCA was viable. He had double vessel disease, recanalized LAD, and then that was a spontaneous recanalization. RCA CTO was a long calcified CTO with ambiguous entry. It was a long one and calcified. Throughout there was a calcification. Fortunately, and Fielder XTR was my first wire for retrograde approach with Corsair with the help of Corsair 150, and then it was escalated to Gaia 2 and then to Conquest Pro after failing to cross the distal cap. And antegradely, because of the blunt entry, I straightway started with Gaia 2 and then escalated it to Conquest Pro. This is the lesion. Fortunately, I had a very good septal collateral, 1 millimeter with direct connection to distal RCA branches. I also had one epic cardiac collateral, highly tortuous, not suitable even for,
Could technical teams help, please?
am I audible?
Yes. Carry on. Yes.
So I could not advance my wire beyond the distal cap. Maybe it was due to calcification of the distal cap. Then I escalated my wire from Fielder XTR to Fielder, then this Dia. OTW lumen of the crusade. Okay, just a minute. Share screen. Okay, so from OTW lumen, I took Gaia 2 and could reach, to some extent, I could reach inside the CTO, I could manipulate. And then when I reached near my retrograde wire, then I
Dr. Arun, we will try to sort this problem from the back end. In the meanwhile, I think we can go ahead with the next presentation.
Okay, so shall I just invite the next speaker?
Yeah.
All right. So guys, it looks like there are some issues. So we'll now like to invite Dr. Rishi Gupta to talk about protecting the side branch in CTOs with rotablation. Hopefully Dr. Bansal can finish the case later. Dr. Gupta, you're on.
Yeah, good morning, chairpersons, my seniors and my colleague. And I'm going to present you a case, which is, I feel is a simple case. It is just, this has some learning point. I think we can learn from it. And this is a patient, this 67 years old diabetic and hypertensive male who came with angina and effort class 2 for last 4 years, and the echo showed normal LV function, and the angiogram showed LAD ostial 100% occlusion with good collaterals from right coronary artery. So this is the angiogram that you can see that the LAD, there is a identifiable proximal cap and some microchannels, but very small area of distal 100% occlusion and some septal and diagonal branches coming near to occlusion. You can see from the contralateral injections that how does it look like. This is the right coronary angiogram, which shows you that the occlusion, and what you can notice from the angiogram that there is a good size diagonal branch which is coming at the site of occlusion, and the major worry was that if you go for an antegrade approach, that very high chance that the diagonal branch will get occluded. So naturally the worry was because that it is getting collateral from the LAD, and I thought that it will create a problem if I go directly to through the antegrade route and I do not protect the diagonal branch. So naturally, the idea was to protect the diagonal branch and then complete the procedure from the antegrade route, because it's a small CTO and a good entry point. This is the contralateral injection. Then you can now you can appreciate that the blockage is small, and you can see that it is a Medina 1-1 type of bifurcation lesion. So idea was to retrogradely wire the diagonal branch so that you can do antegradely the CTO segment, so that the diagonal branch could be saved. Naturally, the diagonal branch was wired with the help of Corsair, and then once the diagonal branch was secured, then it is the antegrade with the micro catheter and filter XT wire, and you can see the lesions. There was a small band at the site of occlusion, and then with the finer manipulations you could enter into the true lumen, and then the procedure afterwards was not very difficult. In normal technique, the lesions were dilated, and the LED and the diagonals both were dilated. And once the lesions could be dilated from the antegrade route, then the wire could be crossed from the to the diagonal from the antegrade route, and then at that moment gradually the retrograde wire was removed. And in the normal way, the bifurcation was tackled with the one stent technique. And this is a long stent from left main to LED, which was implanted from left main to LED, keeping a wire in diagonal, and then the wire was recrossed to diagonal, was dilated, and the patient had, since the ostial lesion of diagonal was very small, less than 5 millimeter, the idea was to put only one stent with the bilateral, with simultaneous kissing. And after simultaneous kissing, the results was quite okay. And then we thought that probably we can avoid putting another stent in diagonal. And the patient did well and recovered well and is doing fine. So this was, the message was simple, that sometimes when you have the bifurcation CTO, then side branch protection requires a lot of attention. And many times the wiring into the diagonal branch, the side branch may be difficult and may require the retrograde technique to wire the diagonal branch, the side branch. And then this procedure can be completed in the way, whether antegrade or retrograde, whatever way you feel like. And this was the only point which I wanted to emphasize, that the retrograde, the side branch should also be taken care of while doing the CTO. Thank you very much.
That was a fantastic presentation. Thank you very much for that. Dr. Sudhir, Rustam, Dr. Pratap, or anyone on the panel, do you have any comments about the case?
Basically, I think, Arun, I did not understand that what was the use of a retrograde wiring in this case. You can have a retrograde injection. That will be useful, but I don't think that will be benefiting the patient at all, because retrograde wiring does not give anything in this case. Definitely retrograde injection is a compulsory thing, because you will be identifying the vessel very clearly. I don't know whether retrograde wiring will give any advantage in this case.
So,
Dr. Gupta, yes, Rishi, yeah, it's a very interesting case. May I just ask, when you said the side branch was dilated, was the side branch dilated by a retrograde approach or
by antegrade, not by retrograde?
So how? So you wired the LED antegradely with fielder XTR, and then you wired the diagonal.
Yeah, wired the diagonal because the wire was already there in the diagonal branch. Then there was no fear of losing the diagonal branch while doing the antegrade section.
Yeah, I think it makes some sense that, well, sometimes what happens in these cases, it was a good collateral, obviously, to start with, that it was a good collateral and you can easily cross it. The fear sometimes is, as we have all seen, when we start antegrade, if the wire goes subintimal, or sometimes it happens subintimal in that case, and the wire tends to go in the diagonal. Now, this case, well, there was a micro channel, it was not difficult. So I think it was all, maybe you are anticipating problems with the antegrade wiring. That's why you did it. Well, and in case if the antegrade didn't work, that I guess you were thinking of doing the CTO segment retrogradely as well. There was no harm to do the retrograde segment. But clearly it all depends, I guess, on the ease of approaching the diagonal. If it was a complex retrograde access, probably you may have just done the retrograde injection.
No, Sudhir, actually, I wanted to make a point very clear in this case. You should not carry on a wrong message to the crowd sitting there. Very, very clearly, in a retrograde approach, in this case with an epicardial collateral, I can tell you that the catheter should be 90 centimeters. You will not be able to take the wire out of the antegrade into the antegrade catheter. So your microcatheter will never go inside. So it is such a long retrograde connection. The most important thing is actually you should have a 90 centimeter short catheter on the donor vessel. Otherwise, it will be very difficult. I don't think he has taken a 90 centimeter long vessel.
This was a short. Actually, once you do the contralateral, once you do the retrograde, you take the short guiding catheter. And the most important part in this case was that if you see that the diagonal ostium was pinched, it was a Medina 1-1 bifurcation, and there was a very high chance that once you do the antegrade, the diagonal may occlude. And the important part was that the collateral to the diagonal was through the LAD. If the patient was not having acute ischemia, but once you are doing antegrade and the diagonal occludes, patient may have acute ischemia on table itself. That was my worry. That is the reason that I preferred to protect the diagonal first and do the antegrade. I don't know.
No, Rishi, there was no problem in that. Guys, but it's only protection of the diagonal wire, it is okay. But the retrograde approach in this case was difficult because of the 90 centimeter short catheter to be used. If at all, you have to do a retrograde in this case because it's a long retrograde connection.
Yeah, correct. I think it is very well taken because it was very long course. You have to take the short guiding. There is no doubt about it.
No.
Okay, guys.
Dr. Rishi, just one more thing.
We have about 15 minutes of discussion at the end. So we can kind of revisit some of these just so that we don't shortchange any of the other speakers. I think both points were very well made. You got to be cognizant of device lens. And again, there are some solutions for it, like using a guide extension in the antegrade thing, etc. But let's kind of save that for the discussion towards the end. I would like to invite now Dr. Kamal Sharma to talk about a long LAD CTO with rotablation. We have 15 minutes of discussion at the end, guys. So just save some of the questions for that.
Good morning, everyone. Respected chair, dear friends. Hope you're all doing well. My case is slightly different, but I assume that Dr. Arun has already shared a lot of things, a lot of important tips. He was there at our center as well once, Arun. I hope you remember that, at being at Ahmedabad, doing a couple of good cases. So this is a 62-year-old male, and this is, of course, after you left, Arun. We picked up from there. So this is a 62-year-old male, COPD, sleep apnea, on nebulizer and night BiPAP therapy, non-diabetic, normotensive, stable angina, 9 months on medication, not willing for any procedure, new onset crescendo angina for a month, already on nitrates, nicorandil, trimetazidine, beta blockers, DAPT, statins, crescendo angina, and a now new onset of rest angina. Resting ejection fraction 48%, LAD territory, hypokinesia. Angiogram showed double vessel disease, dominant left, 100% long diffuse calcified LAD, Syntax score more than 33, of course advised bypass surgery. Neither the patient nor the surgeon willing for the same. Radionuclear scan done, viable all territories except the apex, which was a fixed defect. So distal probably LAD was non-viable. So Dr. Arun already discussed with all the strategies. We intended to go with the antegrade approach, of course, single wire technique, and that was how, and that's what the plan was, to escalate. If required, we'll go with parallel wire, or then if required, retrograde. But the issue was that the RCA was non-dominant, so we didn't have a good collateral either. Of course, this is the algorithm, and I don't think the esteemed panel needs to be discussed all this. So this is the angiogram. You can see a very diffusely diseased in the LAO caudal view and some disease in the other vessels, but circ was relatively good. Not very well filling distal LAD. We didn't have much of a choice to do. So we had to first, as Dr. Arun pointed out, look at whether is the case appropriate to do. Do you need more information? What strategy to do? How do I influence in terms of ejection fraction? And can we consider retrograde? And as per the post-ischemia trial, as we all know, we need to justify the ischemia burden. Fortunately for the thallium, we had a good more than 10% ischemic burden on the LAD territory, and patient was already class 4. So this was pretty much a pre-ischemia versus current practice levels, how it has changed. I don't think this is the talk for the same, but I thought to include this slide to justify why we attempted the same. Of course, the plan was whether to go with drilling versus penetration. Searching, of course, it's safe, but incorrect technique, as now most the Japanese operators would tell us. Penetration, though, is risky, but it's the correct approach. And of course, we all know how to escalate up with the wires. We all know the kind of wires we have. So we decided to go with the Pilot 100 first. We did the left XB 3.5, pilot 100 with double curve because of the double curvature that existed, and we wanted to wire this with microcatheter. So upfront, we took microcatheter up to the lesion, and through using that support, we decided to directly cross with pilot 100 in this lesion. So of course, what we attempted was the perpendicular two approaches, that you go to the proximal LAD, you look at the caudal and one cranial view, and then try to attempt the same. Of course, drilling, sliding, puncture, all the knuckling, of course, as Dr. Arun pointed out, is the last strategy to do. And it's, of course, to have a good backups. That's why the XP was used. And then you can, of course, upstage to do maybe 3, but which we did not have. And we had planned to escalate up to Conquest Pro. You have to visualize the target, as Dr. Arun had already pointed out. And of course, there's people now talking about 3D wiring, soft tissue penetration. We intended to use IVUS if we fail in our wiring, but sometimes you're in for a surprise. You can see this wire actually with a microcatheter support with some amount of manipulation, even despite huge long planning. This is the exit lesion, and then it could just slide through with the microcatheter support. So wiring was pretty easy, but the balloon was a bit difficult. So we took in a balloon. This is 1.25, 1.5 would not go. And this is 1.256 mm. We dilated the distal cap, which was the most tough part. This would not, of course, you can't visualize that 1.25 balloon. And then, of course, the wire would back up when we try to push another balloon. So ultimately, there was a loop that we had to make to keep it in the lumen. And this is after multiple dilatations with 1.5. As you can see, that still the channel is not pretty good. It's a long diffuse disease. And so we actually planned to exchange it with rota over microcatheter with 1.5 or pre-dilate, and probably we were planning to end up with 3 drug-eluting stents. We though intended to do 2 stents only, and then of course the post-dilatation was also had to be done with the opium balloon. So this is the loop of the whole procedure, which I actually thought I will summarize into one single angiogram. So this is once the wire was through, we could exchange it with the rota wire or the microcatheter. You can see the microcatheter, same microcatheter which we had used as support to cross the lesion. And once that was in place, we could rotablate with 1.5 bar, multiple runs, visible calcium there. The distal was the most tough part. The distal cap was pretty tough to crack. And you can see even despite the rota, the artery has not grown sufficiently enough. So then, of course, there was a balloon escalations, 2.5, 2.5. We went up to 2.5 pre-dilatation, high atmospheric pressures, planning to prepare the bed. Of course, we did not have litho at our place, so that was one good choice. We always knew about it, but we did not have a laser to tackle this kind of diffuse disease. Probably it might have helped us. This is, of course, not only in the hindsight that we felt so, but it was upfront also planned, but that was in Feb that we did not have laser availability in the institute because of technical issue. We went ahead with the first stenting, distal most, and we thought we may get away with 2 stents. Post dilatation, second stent, relatively low, okay. Then we took opium balloon because the lesions were not giving way. We dilated with the opium proximal part, in stent, and opium we have often used pre-dilatation as well. This case, we did not use it pre-dilatation. That might have been a good strategy, probably retrospectively looking, we thought. But then opium we have used here at post-procedure, post-dilatation, and again, even distally. So once we have done dilatation here, you can see still some residual bad disease distal to the second stent. And then we realized that probably it's not going to go. The artery has grown tremendously. Imaging was one more thing that could have helped us to size it. But again, this was a Yojana patient, and budget limitations always cut through in Yojanas. Being in the institute, we could still afford to do all this. So this was the third stent. And then you can see this is despite full 18 atmosphere deployment, it would not trumpet. And then again, post dilatation. And then we had to take an opium balloon to do the pretty high pressure dilatation up to 32 atmospheres repeatedly. And then relatively acceptable result at the end, and patient is doing well now. 3 months of follow-up, normal ejection fraction, class 1, his angina has gone. He's on DAPT statin nitrates and beta blocker, which is respiratory friendly, of course, being a bad COPD. But he's off multiple other multiple other anti-anginals that was bothering him. Thank you very much. Thank you.
Yeah, good case, Dr. Sharma. May I just ask, obviously, as this session is tips and tricks, and obviously the message is going across to wider audience. We didn't see the baseline coronary angiogram, so it was not clear whether this was a true CTO or a subtotal severely heavily calcified lesion, because you did this case, it looks like, with a single catheter. There was no retrograde injection involved. I would be a bit skeptical about using all these devices unless I am 100% sure my distal wire is in the true lumen. So as a basics, if you can see the distal wire as well, I would always put dual lumen, dual angiography, bilateral angiogram to see where my distal wire is, because it might be sometimes very tricky. Once you pass the devices, you might lose flow in the artery. And so those kinds of things, simple things, but you did the case very well. It was heavily calcified. We can see the wire was in the distal true lumen, but we didn't see the baseline angiogram to appreciate whether this was like a very heavily calcified lesion which was have some antegrade flow, or there was no flow in the distal LAD.
Yeah, so I'm sorry I could not share the right angiogram because right was a non-dominant, and of course there was nothing filling up, so I did not include that in the picture here. The left was the dominant vessel, and there was practically no good collateral distally to the vessel, but I thought of skipping the right, but your point is well taken.
Another learning point, Dr. Sharma, from the beginning I assumed that it is all ipsilateral collaterals because, again, there was no second guide. Sometimes you just need to take 7th range to allow microcatheter to the dominant vessel that gives ipsilateral collaterals. Given the case was very calcified, that was very forgiving for many injections. Otherwise, if it is not much calcium, then the vessel can shut down. Doing rota, yes, it's 125. It's relatively safe. Pilot 200 or 100 as you took could partially sometimes come in and out of subintimal space. Rotating that, as Arun showed in his first case, is safe with 125. And sometimes once you achieve that and you balloon it all the way, maybe it's questionable to stop and bring the patient 3-4 weeks later and just minimize the stent, because essentially there is full metal jacket, and in calcium, as you know, even though you did really well, sometimes long term it may require more interventions.
Yeah, your point. Sudhir and Rustam, anyone on the panel have anything to weigh on in the about the case? Dr. Neeraj, anyone else? Dr. Deepak, Prabhakar, any other comments at all?
Hello. Yeah, I was just wanted to know about the antiplatelet strategy here, because we have 3 long stents and very little distal runoff. So what would be antiplatelet strategy and for how long?
This patient is on prasugrel aspirin now for 3 months, and we intend to continue it for a year.
For how long prasugrel, Dr. Kamal?
For a year, as most of the guidelines tell us.
For a year. And what kind of restenosis are we looking at here with 3 long stents in calcified vessels?
Dr. Arun, I think with each probably around 15% of restenosis, that's what we have counseled. 15 to 20%, that's what we have explained to the patient. If there is anything different that you would counsel, Dr. Arun?
I mean, I guess this patient, you kind of have to play it by the ear. I definitely agree that imaging could have been helpful. And I also, you know, in terms of, I think Rustam made the case that sometimes less is more. But again, I mean, now that you're kind of, it's committed, it's committed. But, you know, it's always a good idea sometimes to just wait and see how the vessel plumps up later on follow-up. But I also understand the realities are some of these patients don't come back and yada, yada, yada. So we have to deal with the ground realities. But in an ideal world, yes, I would have used imaging, probably lesser stenting. But now that you're committed, you would try to keep this patient on for as long as possible. The key is whatever antiplatelet regimen you have, if distal runoff is a problem, then you are going to have a challenge. But I think it was kind of acceptable here. So I'm hoping that things are things work out well for the patient.
But I think, Kamal, I have a doubt that what is the size of the stent you used? What is the diameter of the stent?
Sorry, I didn't mention it in the presentation. The proximal stent is 3.5 by 38, followed by 3 by 30 in the middle part, and then another one 2.75 by 24. So those are the three overlapping stents: 38, 3.5, 3, and 2.75. Then post-dilated with 3.5 balloon proximal in the mid, and distally we have done OPN 3. So,
but if you look at the angiogram, actually, I don't know, the imaging was not done. I don't think that is achieved even 2.75 proximally. So that is actually one of the basically that the comment made by Rustam is actually very, very important because of the high chance of restenosis in this case. And he was telling that we can leave the patient with after a rota. I think we can even leave the patient with a rota with a drug-coated balloon in a diffuse disease, and then check angio after 2 weeks or 3 weeks, and then see that if there is a problem, then you can put a short stent and come out.
Agree.
Points, and it also illustrates that you got to make sure, now that we have OPN in the last year or so, definitely, I mean, it's kind of a crime to leave an underexpanded stent. So I think it was good use of that. But again, I think sometimes it's good to stage. So now we do have Dr. Bansal back on. I think the problems have been fixed. So would love to kind of see the rest of the case.
Thank you everyone.
Yeah. My case was a 51-year-old Iraqi male presented after failed attempted PTC of RCA CTO with symptoms of effort angina class 3 and dyspnea class 3. His LAD was infarct related, and but the RCA CTO was supplying a viable RCA territory. The CTO score was 4 by 5, and then straight away I'll come to the case. AL1 with side hole was taken. The stump was very small. The entry was ambiguous. The two side branches were coming from the entry point. The CTO segment was long and it was calcified. The bridging collaterals were small and inadequate. That is why distal vessel was not very poorly visualized. But fortunately, I had a CC3 collateral for a septal collateral, which was 1 millimeter and was directly connected to RCA. Also, I had epicardial collateral, but which was very tortuous. So obviously the choice was septal collateral, because the antegrade attempt in the past could not succeed. So I decided to start retrogradely. And I started with Fielder XTR wire with Corsair 150. But the distal cap could not be penetrated. Then I escalated my wire to Gaia 2 and then to Conquest Pro. Still, I could not pass through the distal cap. Then I shifted to the antegrade approach. Initially I took a workhorse wire over which I passed my Crusade catheter, and from OTW lumen I passed the Gaia 2 wire. I tried to cross the CTO with Gaia 2, but I was not sure whether it is in true lumen or not. So, but when the wires were very close to each other, both retrograde and antegrade, I checked in orthogonal view. It was quite away from the retrograde wire. So I thought it is not in true lumen. Then I redirected the wire, and in orthogonal view, it was on the other side, and tactile feeling gave me a feeling that it is in the correct lumen. So I decided to advance it further with the help of, this is a Conquest Pro wire, which could sail through the true lumen of the CTO, but it was not going any further after this point. This was actually, it was not going beyond this point because of the extensive dissection. You can see that my Corsair was also in the false lumen. And then when number of attempts were done with the help of Crusade, I changed to many wires. Every time my wire was going into the false lumen. The CTO area was nicely opened, and that the entire area is true lumen. But distally, my wire was in false lumen. So that is why, I was trying to enter into the true lumen. Finally, I tried to do it with knuckle wire technique. That also failed. Then I decided to consolidate my gain, and for better visibility of the distal part, I stented the proximal gain. So CTO area was stented. This gave me a chance to try more with the help of Crusade to re-enter into the true lumen with different positions of Crusade and trying in different angles of the wire. I could ultimately enter into the true lumen and then dilated the with a balloon. The dissections were both retrograde and antegrade because of my multiple attempts antegrade as well as retrograde. So that is why this dissection was really difficult to, it really took several hours to pass through this dissected area with the help of Crusade, of course. But I could be successful only after stenting the proximal CTO segment and ostium of the RCA. This was my final result. And my main point, the main take-home message is that, if you continue trying with the help of Crusade, it really helps. It is better to use Crusade for crossing the dissected segment, because Crusade helps in redirecting the wire in the true lumen. If you try parallel wire without Crusade, it tends to go into the same lumen again and again. You can't change the direction very easily. But with the Crusade catheter, you can easily enter the, it is much easier to enter the true lumen. So that is why, Crusade was very helpful in this case. And of course, this for CTO, even when antegrade or retrograde was, not helping me, the orthogonal views helped me to, enter into the true lumen. Multiple attempts, of course, were done. And because of calcification, antegradely, I could cross only with Conquest Pro wire, and distally also probably I was in false lumen. That is why so much of extensive dissection was there. So all these, and I always gave a very small tip, 1 millimeter tip at the in the CTO wire, and I keep my Crusade around 1 centimeter away from the tip of the CTO wire. The Crusade is kept around 1 centimeter so that it gives better support and better maneuverability without kinking through when you are passing through the CTO. So all these small points has helped me. Of course, the guide support was also good, and Crusade was the most useful catheter in helping me to re-enter through the proximal cap, ambiguous proximal cap. With the help of side branch, I could negotiate it into the true lumen. Thank you very much. It was a case which I thought I should share. It might be a good case for discussion.
Good case, Dr. Bansal, and very well rescued. So to just summarize the case, you started with retrograde, but the case was done by antegrade wire escalation.
Yes.
Now, the one thing I was not clear, that you were already in the mid vessel with the retrograde wire, and your antegrade wire came up to that place, and all the misstep happened distally. Why did you remove your retrograde wire? Because that would have helped you in avoiding the distal hydrogenic dissection in the distal RCA.
No, my retrograde wire was also in false lumen, and retrograde wire, actually when I entered the antegradely, I could reach much beyond the retrograde wire, and the antegrade wire was getting stuck in the distal segment of the RCA. So I thought retrograde wire is not giving me any guidance because it is already in the false lumen. And when I removed, of course, when I pulled it back, I did not remove it completely. I just kept it in the PDA.
Because this could have been a good case for reverse cart. Your antegrade wire came very close where the initial retrograde wire was, and you could have brought down the guide liner. And that could have been...
No, the wire was in the, both antegrade and retrograde wires were basically not in true lumen, and the wires were not close to each other. There was no overlapping for the reverse cart.
But still, you were very close to finish the case if you just balloon the antegrade subintimal space, brought the guide extension there, and you could simply rewire on the retro wire. You're very close to finish there. And then I agree with Dr. Sud here. I would still, if I changed my strategy and went antegrade, I would still keep retro wire. That would help you as well as a marker.
Okay.
Well,
Fine. Point well taken.
There are 2 points
Dr. Bansal, great case. And I think we all echo what pretty much Sudhir and Rustam have kind of just said. In general, these days, we are not tending to do the stent initially, like, using a guide extension catheter might save you a lot of trouble. And also, I mean, one of the things is that, there's a lot of stuff made about, is the wire intraluminal or is it not? It is really, really hard to tell, especially retrograde with a Gaia when you have a microcatheter as to where exactly you are. So in general, don't lose ground, I think is a good cardinal rule. But again, great save and very well done.
Thank you very much. Thank you very much.
I'm sorry, Dr. Pratap, you had something to say?
Actually, I had 2 comments. Basically, one, he should not have stented. Number 2, when you are actually a reverse cart, actually in this case was very important. Even after stenting, he could have taken the retrograde wire again and he could have gone through inside. Rather, there was a chance created some disruption in the distal part. You have a stent in the proximal part. You could have taken a retrograde wire already passed. You could have gone through the stent inside and reverse again. You could have come through the retrograde in the distal part of the arch. That was another possibility. Okay.
Anyway, I tried distally to cross the distal cap. Somehow even the Conquest Pro was kinking again and again. It was not able to penetrate through the distal cap. So I tried very hard.
Okay. It was well done. Actually, the final result is looking very good.
Thank you.
Exactly. So I would now like to invite Dr. Mukherjee for presentation as a case of LED CTO osteo.
Good morning, everybody.
Good morning. Go ahead.
Please go ahead.
So, the cases of chronic total occlusions, they comprise nearly less than 10% of my practice. As a early practitioner, I do these cases very less often as of now. So this 65 years old man presented to us with a typical class 3 angina. And, he
Dr. Mukherjee
in his symptoms. He was suffering from hypertension for a pretty long period. He was a smoker. He had underwent coronary angiography 1 year back, and it was suggestive of a total occlusion in proximal LAD, and he was put on medical management. But despite optimal medical management, he was not responding to the medical management. So the decision to intervene, the LAD CT was taken. So as we can see, the total occlusion was right from the ostium. So the CTO was defined in multiple orthogonal views. This was the elaeocranial view. We can see just after the ostium there is a stump, and otherwise we could not see anything. So the origin of the RCA was ectopic one. So we had to take AL1 to engage the RCA, and by taking the contralateral injections, we were able to define the collaterals and the filling of the distal LAD. So this was the lesion, and it was defined in multiple views. So we have a chronic total occlusion in the proximal LAD, which is right from the ostium. It is a short CTO, we can say, and it is a hard type of lesion, but there is no obvious calcification seen in this CTO. So as is usual our practice for CTOs, we preferred femoral approach, and we took a 7 French. Usually we take 7 French guide catheter. In this case, the tortuous femoral vessel was tortuous, so we opted for a long sheath. We defined the coronary anatomy using contralateral injections, and the cath table was obviously not panned while we were doing the case. So, considering the anatomy, the guide which we opted was extra support. It was a 7 French guide, extra supporting guide, because we need to maneuver the devices, wire, so that the crossability improves. So the selection of the wire was done based on the lesion characteristics. So we opted for a Fielder XT wire. Fielder XT, in this case, we opted because we thought it is a relatively softer plaque. These are the various escalation criteria for using the or selection of the guide wire. Probably the most important thing in managing the CTO is the selection of the guide wire, because crossability depends on the guide wire. Of course, experience does matter, but if you select the right hardware, so the success rate of the opening of CTO will be high. So in this case, we opted for a Fielder XT wire. If it would have been a more stiff lesion or a hard plaque, we would have gone for wires with a higher tip load, and that is the thing. So initially, definitely we used microcatheter because exchange of the wire or escalation is more easy than the while we escalate, it allows the wire to be delivered exactly at the same point, and definitely it provides support. So graded balloon dilatation was done, starting with the initially 1.5 shortest 10 millimeter balloon, and sprinter balloon was used. After that, we dilated it with 2 mm balloon. Whenever we pre-dilate with any balloon, prior to dilatation, one thing we can do, we can just arc the balloon beyond the site of the chronic total occlusion and take a small injection, so that we can confirm whether we are in true lumen or not. It helps many times. Many times you may not get any flow, or you cannot define the distal vasculature, but many times, majority times, you can see some of the septals or branches, so that we can be sure before dilating the vessel. So this was the 2 mm balloon, and dilatation was done. This was after pre-dilatation. Proper preparation of bed in CTOs is very important, because delivery of the stent will depend on preparation of the bed. Initially, we may use non-compliant balloon. If required, we can use open NC balloon. And even after that, if there is a recoil, or you are not happy with the visualization of the vessel, then even rota ablation may be required. So after this, we selected a stent. It was a 2.75 by 30 mm resolute onyx stent. It was placed with the point that circ does not get compromised. And so right from ostium, the stenting was performed. So this was the angiogram immediately after stenting. So this was in cranial views. After this, we performed post dilatation using a 2.75 by 15 mm sprinter, 12 mm sprinter NC balloon. So this was the final result. So we did this case. The purpose of showing this case is for the early practitioners, we should stick to the basic principles of managing a CTO. So that is the femoral route will be preferred as compared to radial. We should use higher sizes of sheaths so that it provides us, we can select for a large size guide catheters. Long sheath will help in tortuous anatomies of the femoral and iliac arteries. We should assess the anatomy of the CTO in orthogonal views utilizing contralateral injections, keeping the cath table static. We should not pan it. Adequate guide support is a must because we have to deliver the devices in such cases with a very difficulty or with resistance. So proper selection of guide wire is vital to the success of CTO. Preparation of bed is important for the stent delivery, and we should know when to stop when we are doing a CTO case. Usually, I think more than 30-minute time is an indication that we should not go ahead, and either we should take help of some senior person or we may think of a surgical option in managing such cases. Thank you.
Great talk. Any of the panelists or the co-chairs, do you have any comments about the case that Dr. Sachin just presented?
Well, it was a case very well done. Clearly, there is nothing like simple. So you've taken all precautions, bilateral.
I think we just lost Sudhir there briefly.
Arun, I have one point to make. It was a well done case, but actually I think there was no other option of a retrograde CTO because the only collateral which was seen was a difficult one. So he should have definitely gone with the normal wire escalation technique in this case, and it was well done. And he has chosen the real wire in this case. I think that was
important comment I would like to make also. There were, I think, too many antegrade injections. At the beginning, when the lesion is not open, obviously retrograde injections would help. Once the lesion is open, obviously retro doesn't work unless you inflate balloon in the CTO to allow retro injection. But still, if patient is stable, no ECG changes, no sudden chest pain, 1.5, 2.0, 2.5, 3.0 balloon dilatation do not require any antegrade injections, I believe. So in cases like this, you have set up pictures, approximately, let's say 15 millimeters, take 25 millimeter stent, position it well. If you don't have imaging, just deploy it. Yes, there is a possibility you may need another stent lower, below that, but most of the time it will be better. But if you keep doing injections, I'm just telling this for learners, then obviously you will deal with longer stenting. Most of the time, you do not need to do pictures after each balloon. That's the point.
That's a valid point.
Point taken, sir.
Great points. Yeah, and in general, like if you're not sure about the position, it's also a good idea to avoid antegrade injections just in case you do have stuff in the subintimal space. You're going to create a really big hematoma. So as long as you have imaging from the contralateral side, I would highly encourage that.
So like in this case, Arun, as soon as they open the proximal flow, antegrade obviously stop the retro flow. Again, to avoid antegrade injection, you can always inflate a balloon
antegrade and take an
and do retro. It will work.
Yep. Hey guys, we're going to have a small change in schedule. We're going to have Dr. Barua before Dr. Akshay. So I would request Dr. Barua. She has a emergency, so let's just switch.
Okay, thank you.
Morning. Morning, sirs, moderator and panelists.
Good morning.
Good morning. So my case is basically a not very challenging case, but considering the resource constraint in working in my cath lab, so sometimes I face difficulties and these challenges. And I used to keep some of the devices in the shelf so that during the bailout it helps out. This is a case, 56 years old female, and she presented with chronic stable angina class 3. Despite of a lot of anti-ischemic therapy, DAPT and anti-anginal, her angina persisted, and the ECG in the resting state was normal, and the echo showing good ejection fraction, and there was no rest RWM. And risk factors is prevailing with diabetes, hypertension, and also dyslipidemia. And she is having normal renal and liver function. This is the case, right dual injection showing that there is a critical stenosis in the distal part of the RCA. And considering the vessel size, it seems to be not very significantly bigger vessels, maybe moderate size vessel. And but in spite of the anti-anginal therapy, is optimal therapy, she is still presenting with a lot of angina. So I decided to go ahead with angioplasty of the RCA. And while negotiating this lesion, I thought that there might be some microchannels, and then it is easier for me to cross with a filter XTR. And initially I tried to cross with filter XTR, but it doesn't go with fine cross microcatheter. And then after tired work for at least 15 to 20 minutes, I switch over to Gaia 2. And then this Gaia 2 wire is crossed with the help of the microcatheter assembly. And then I thought then it will be easier for me to cross with any balloon. So I first tried 1.2 millimeter traveler balloon, but it doesn't cross. And this is the minimum size balloon actually we usually do have in our cath lab. But luckily I have one CTO balloon, that is reverse CTO balloon, that is 0.75 millimeter. And then I tried with that balloon, and luckily it went through the this very critical stenosis. And then the rest of the part is not very difficult. So, and then we dilated with a 10 millimeter balloon, and then we give a lot of nitroglycerin intracoronary to exactly see the accurate size of the vessels. But the vessel didn't yield too much, and it seems to be distal vessel is not more than 2 millimeter, maybe 2.2 to 5 millimeter. And then before that, actually, we exchanged the Gaia to with the help of the microcatheter to a BMW wire, and then the rest of the balloon expansion, pre-dilatation, and then stenting was done with the help of the BMW wire. So this is we placed two overlapping stands, distal 232 millimeter and proximal 2.5 16 millimeter overlapping balloon, and then post-dilated with 2.5 millimeter MC balloon to high pressure to 20 to 22 atmospheric pressure. And finally, we have found a good TB flow in the vessels. And then while following up the patient, it seems that she remain angina free, and she is on DAPT, clopidogrel, and aspirin, and high dose of statins, and anti-anginal medications like nitroglycerin was stopped. This is another case of almost similar type of lesion. This patient presented with unstable angina, and there was ST depression in the inferior leads, and ejection fraction was normal. And we have seen mild wall motion abnormality in the inferior wall, and there is normal renal and liver function, and she was on optimal medical therapy, anti-anginal medication, a lot of anti-anginal medications, nitroglycerin, and also nicorandil, along with the DAPT. And this patient is also a diabetic, hypertension, and dyslipidemia, other risk factors. This is almost similar. Looking at this case, I thought that it is not be very difficult to cross the wire with a filter XTR, but it didn't go. I thought it's very critical stenosis, and then finally again I have to resort to this Gaia 2, and then again this 0.75 CTO balloon, reverse CTO balloon helped me to because I do not have a rota ablator at the time. So I thought that this balloon might help, because 1.2 millimeter balloon was not going through the dilation, and we dilated with 0.75 millimeter and CTO balloon, reverse CTO. And then rest of the procedures was not very difficult. We exchanged it with the help of the microcatheter to a BMW wire and dilated with 210 millimeter balloon. And then ionic stent of 334 millimeter stent was deployed, and post dilatation was done with a high pressure 3 by 15 millimeter balloon to 20 to 22 atmospheric pressure. So I just want to show this slide because this is in resource constant setting. Sometimes it helps to bail out, and this is a rapid exchange catheter as a very high pressure we can generate. It's a semi-compliant and dual lumen catheter, and the outer lumen for the inflation and the inner lumen for the guide wire. And there is a distal tip is tapered that it helps to be negotiated tight lesions. And there's 2 radiopaque markers, so exact placement of the balloon is helpful. This is the chart. These balloons are available from 0.75 to 1.25 millimeter size, and the lengths are 10 to 40 millimeter. And we can generate RBP to 18 atmospheric pressure, and the nominal pressure is 8. The take-home remarks that CTO intervention is mostly complex procedure, and it needs planning, nevertheless effective devices. Reverse CTO balloon may be useful in non-negotiable lesion following the wire crossing. And technically, it may not be very difficult during the procedure, but at times it could be quite helpful. And this balloon can be kept in the shelf for CTO armamentary. Thank you so much.
Great talk. Hey, one thing that I couldn't help but notice is, I think, balloons have become increasingly deliverable. What was your choice of guides? It seemed like you were using JR mostly.
Yeah, I have used JR catheter.
So one of the important things is, with CTOs, as I think a lot of you guys are well aware, especially for those that are starting off, backup matters a lot. You will run into this problem where wire gets across, but device doesn't, be it balloon or microcatheter. So I think the first and the most important step is make sure your backup is really good. Use a little bit more aggressive guides such as amplats, and many times you do have to use guide extension catheters. Again, just something for people to consider, especially if you don't have a great guide. JR doesn't give you good backup with the real CTO. So anyway, that was just my 2 cents, but very nicely done.
Yeah, Baru, I have 2 points to tell. You should not think that if the wire is crossed, you may think that you are going through the true lumen all the time, but you may be going subintimal and then reaching the intimal. That is a situation most of the time, no balloon crosses. So there are 2 advantages in this case. You can put a PK, keep another parallel wire and go into the true lumen and enter inside if you don't have a balloon like this. Second choice is you can take a channel dilator like Corsair. You can actually create a channel and then go inside. These are the 2 other options left out. But I was actually a little worried about their stent sizing. You told a 2.25 size stent in the RCA in the first case and a 2 millimeter stent in the distal part. I think it is very, very little size. Any RCA cannot be less than
2.5 in the proximal.
But 2.5 is a very, very less size stent. In our right coronary artery, you should have a 3.5 or 3. If you start doing IVAS, you will understand the vessel size. The stent we use actually a very, very less size.
Unfortunately, we do not have IVAS. That's the issue.
But actually, you should try to use a bigger size stent, not 2.5. It is little, very, very less, I think.
Yeah, I agree here. There are multiple possibilities how to sort lesions where wire crossed, nothing else crosses. But the cheapest and the most important solution is what Aaron said, is to choose appropriate guide. AL here would be much more useful. Now, on the note, because Translumina is around, I don't know if you have it in India, there is also OPN nano balloon, which is 0.85. It has only 1 dot and it's in the back, it's not in the middle. And it can go to 23 atmospheres. You can use normal inflator for that. So it's something to consider.
You're talking about the Nick Nano, right?
Yep.
Yeah, great balloon.
And who makes this river balloon? Who's the manufacturer for river CTO balloon, Dr. Barua?
This is Belton company from Poland.
Right.
Belton.
Yeah, and there are a few other balloons. We normally use, Acrostag balloon. One of the Acrostag balloons is good as well. And a Sapphire. 1.0 Sapphire and 1.0 Acrostag balloon we found quite useful if the 1.25 doesn't cross.
honestly, I think balloon technology has come a long way. I mean, like there used to be a time when we used to just say, hey, microcatheters are clearly head and shoulders above balloons. But these days, I mean, Nick, no, I know, I mean, I haven't personally used River. Acrostat's great. Rearray is a great balloon. I mean, there are so many balloons in the market right now, and some of them really give the microcatheters a run for the money, even in septals. And sometimes when things just don't cross, you could use those. So great presentation again. And I'd like to now invite Dr. Who's the next speaker?
One speaker you actually made, you did not call.
One of them is waiting, right? Okay.
Yeah.
We did switch. Okay. That was Dr. Akshay. Dr. Akshay, right? Dr. Akshay Bafna?
Yeah, I'm here.
Yep. Hey, you're on.
Yeah, sir. Yeah, good morning, everyone. Presenting an interesting case of an angled CTO. This was an 81 years old female. She was an obese, actually a mother of an physician, well-known physician here, and she was an hypertension, non-diabetic. She also had an cortical venous sinus thrombosis in her pregnancy days, which was way back something 50 years back. And she has to have an angina on exertion since probably 3 to 4 months. And she got admitted in an emergency medical room for chest discomfort and sweating. The ECG was done, which was showing an ST depression, as you can see in the precordial leads, particularly V4 to V6, and subtle in to an AVF with subtle ST elevations in AVR and V1. And troponin was done, it was positive, it was raised, and CPKMB was 83. 2D echo showed no any regional wall motion abnormality with ejection fraction of 55% with grade 2 diastolic dysfunction. So we went ahead with so we went ahead with the angiogram. Is the angiogram visible?
No, we can't see the angiogram.
The angiogram is not visible.
Okay, just a moment.
Okay. Still not.
Yeah, now is it visible?
Yes.
Yeah. So this was the right angiogram was normal. It was showing only just grade 1 collaterals to the left coronary artery. And we can see this, there is an just at the origin of like diagonal small caliber LAD and the septal branch, there was a lesion which was seen. So we thought it would be a near total occlusion and seems to be an acute on chronic sort of an occlusion. We went ahead with the crossing of the using an EBU7 French guiding, and we used initially a filter XT wire, but we were unable to cross it. And then later on, we stepped up to the cross it XT100 wire. We were trying about to the best, but we could not negotiate it. We tried our best, but later on, then we put up another one wire into the diagonal branch, and we engaged that wire, and we started to again attempt to going into the true lumen of LAD. Since it was an angle, we gave a multiple times of different angles. We used almost couple of wire, but still we couldn't be able to negotiate across that to the lesion. And later on, then we stepped up the wire, we crossed it 200 this time. And we tried again after giving an angle, but again, it was not possible. But somehow by using a assisting balloon technique, like assisting the balloon, we finally crossed the lesion. Once we have crossed the lesion, we exchange that wire with filter FC wire. And then by sequential dilatation of that lesion, we could negotiate that lesion and we could open up. After opening of the lesion, we appreciated that there is probably the entry at the proximal level. We had an entry, then again subintimal, again then true lumen, and we came into back into the true lumen. It was. You can see here, obviously there is a dissection which is noted in the proximal segment. We ballooned it first, but however, with the small on a push of the balloon, we could dilate the balloon, and after dilatation of the balloon, we could able to appreciate little better angiogram and views also, as is seen here. Still, there was a subtle dissection which was noted, and with the flow restriction to the distally, not a good distal vessel. Then we plan to stent the distal segment using a 2.5 32 mm DES, and later on then so this was we went up to the nominal pressure, and then proximally we took the size and we found out what was the exact length, and used a 2.75 proximally. The 2.75 is 32 mm proximal DES, and we inflated at a nominal pressure. We can see the vessel is better visualized, and later on again we post dilated with using 2.75 at 18 atmosphere to 20 atmosphere. So this was the final results we got. The distal vessels are it was diffusely diseased, however it was filling with TIMI3 flow distally, and the flush grade was also good. So yeah.
So, Dr. Bafna, is this your final slide?
Yeah.
Are you done?
Yeah.
Okay, it's well done. There are a few points I would like to make here, starting from obviously the angiogram. If you look at the angiogram,
yes,
there was obviously you can't see the microchannel. What you can see is there was a so when you see the injection step by step, it was occluded just before the LAD diagonal bifurcation, and the distal vessel and the diagonal was filling via retrograde epicardial collaterals, and that's why you get a sense that there is a microchannel.
Yes, sir.
Yes, secondly, you did well. Obviously, this thing happens very often that the wire goes into a diagonal branch. But why did you remove the diagonal branch? Because you've lost the diagonal branch when you crossed, and it is not a very wide branch, but if you look at the NUNH score for side branches, it is a long branch and it is supplying a substantial myocardium. There's no further diagonal further down, because this is commonly happens. There is a subintimal, intimal, subintimal, intimal entry. So I would have kept the diagonal wire there and also dilated before putting the LAD stand. That's my comment. But you did very well, and your point is quite clear.
Actually, I think I wanted to make one comment. Actually, you should have put the wire when you are actually not able to cross the wire into the LAD or diagonal initially, and you are actually coming with a balloon of, I think the wire was with a balloon coming inside. First proximally, I can see two markers there, you see. So I don't know whether actually you could come with a balloon initially or not. This is two markers. What is this markers? This balloon?
Yeah, this was a balloon, sir. We actually used 1.25 balloon. We had one balloon with a double marker, and it was around 8 mm in the length.
This is what I wanted to make a message. Actually, when you are actually having a difficult lesion, you can go with a microcatheter, never with a balloon. And balloon actually will not give you a support down, and it will be creating more damage to you. Number one. Number two, you could have kept a wire into the major septal artery, which is a very, very important vessel. If you lose the septal, and with you, if you put a wire down septal, then you take another wire in a microcatheter, your entry would have been much, much easy. The angulation would have been lost by keeping a wire into the septal artery. You could have easily kept a septal artery, second wire with a microcatheter, you would have definitely entered. And I think that is the crux of this case. I think I personally.
Great points, Sudhir and Pratap, and I mean, nicely done, Akshay. So just a couple of things, just to echo, we don't really use balloon support these days for CTOs. I think in 2020, I would highly encourage you to use a microcatheter. That's number one. And number two, is sometimes, let's say you do get the diagonal. Another thing to consider is to use a dual lumen catheter at this point and try and, because you know you're in the true lumen and the diagonal. So using a dual lumen catheter, getting into the diagonal and then getting, kind of pulling back and then wiring the LAD might be a much safer approach if you do have a dual lumen catheter. Anyways, nicely done, nicely finished.
Okay.
Any other comments from the panelists?
I have a comment. Sometime if you don't cross into the LAD, I have seen if you are not able to cross the LAD, doing a balloon dilatation into the diagonal in the proximal segment, you change the angle and you open up the vessel better, and then you can sometimes able to cross into the LAD. So that's also a thing you are not able to. That message is important when you actually as the last resort. I'm just telling you, you go into the diagonal, and if you put a balloon dilatation, you may dissect the vessel and you will never enter the LAD is also a possibility.
Yes.
I fully agree with Pratap there. I mean, don't do it unless you have run out of all options, because that's an act of war. What if you, let us say, when true falls through into diagonal and then balloon it, you would have just lost your LAD axis and created a dissection plane that goes into the LAD, and then it's really hard with the angulation. So no, I would agree with Pratap 100% there.
Yes, sir. Yes,
I would argue a little bit on this. 1.5 millimeter balloon dilatation would not hurt. It's very similar to the first case presented today, where the wire, let's say, goes to diagonal. You have distal bifurcation at the cap. 1.5 balloon dilatation would dilate the whole CTO body up to the bifurcation, and on subsequent single injection would allow better flow. Then usually second wire or dual lumen catheter may help. I agree not to go any higher than that because of risk dissection.
Rustam, a dual lumen catheter is probably the way to go. You don't know if you're going true falls through to the diagonal, right? I mean, people use aggressive wires and balloon for support. You have no idea what to track into the diagonal.
Quite often, Arun, in this kind of calcified lesion, it's impossible even to deliver a dual lumen catheter, especially if you have crusade or all twin pass to diagonal, let's say.
Sasuke is pretty darn good.
Yes, absolutely. If you have Sasuke, that's excellent. Yes.
Any comment from Dr. Rishi Gupta? Is Dr. Rishi Gupta still here?
I think this is very challenging situation. Actually, we find in day-to-day working, we find many cases like this, and it is very challenging to enter into angulated lesions. And normally, most of the time, it requires a lot of patience. And what I found that the most of the time, it is the filter XT wire which is able to go. And naturally, by changing the angles, by keeping the wire in the edge, suggested by Dr. Pratap as well, that keeping the wire in the other branches may sometimes change the angle and you can go inside the angulated lesions. Of course, the dual lumen catheter is many times very helpful. If you can go, but as Dr. Rustam said, that it is like a lesion which has a very hard lesion before, it is even difficult to push the double lumen catheter. It becomes very challenging, especially if the band is after a very tight lesion. It is,
in this case, I have a comment. I have a comment. In this case, the angle was such that it's not a very favorable angle. So why use cross it 100 and 200? Stiffer wires more likely to dissect.
That was kind of what we were getting at. The issue I think in India is that, and I think globally really, is that it is very hard to teach people wiring. I mean, if you look at some of the most experienced operators in the country, and I mean, without naming people, some of them have kind of trained and done hundreds of, if not thousands of cases with the CrossFit XT, 100, 200, 300. That's their algorithm. So if you take a person who has done a lot of cases on these and try to re-educate them on some of the newer wires, it gets really hard. Wiring in general and teaching people is very hard. And that's really kind of what I think part of the concern is. If you've used a wire that is not so aggressive, I think even, ballooning a side branch is reasonable, as I think Rustam said. Sometimes with these more aggressive wires, you don't know how you've really tracked it. But again, for those that are learning these days, I think CrossFit XT is a fairly antiquated wire. Today's wires are probably, with the Fielder series, and then, probably one of the Gaia and the Gaia Next in the future. I would love to hear what some of the other guys think. And we have some new wires coming out too, like the Mongo and the Gladius, etc. So Rustam, do you guys have it there? Sudhir, do you guys have the Gladius yet?
Yes, we have the Gladius. Yes.
Recently in New Zealand, before pandemic, I tried next generation Gaia. Mango also will be available very soon. But let me just tell you about this case after case I observe. I would suggest minimizing antegrade injections. In cases like this bifurcation, for example, what I do, I usually take a good shot at the start, ariocranial, put it as a map in front of me, and just, let's say, wire went to diagonal, keep it there. Another wire can go to septal if you want, and just keep trying probing with very soft tapered wire, see if it goes. But I would, and few other techniques, but avoid injections, because then otherwise you have to stent, long stents instead of just short single stent.
I couldn't emphasize enough. Avoid injections, antegrade. More injections, more chance of dissection, more contrast, especially in elderly. So fully agree there, Rustam.
I have a small presentation, Arun.
Okay, let's.
I don't know. I think that is the last presentation. I think.
Do we still have Dr. Ragani?
Sir, just to end up with just a few some take-home messages to understand why to treat in the CTO, when to treat a CTO, to understand pathology. Yeah, so these are the 10 commandments what I was being taught, and I probably discussed, though I'm not doing so frequently, is the CTOs. As Dr. Sachin has also mentioned, less than 10% of cases I have in CTOs. But this was in a physician's mother plus aged, so it was little of this thing about the expectations. So
Dr.
just
we are really short on time at this point, so I'm going to give you like 30 seconds to wrap it up.
Yeah, sir. That's it, sir. That's a finish. Just only I want to say, keep it simple and safe, sir.
Emma. Okay. Dr. Ragani.
Emma. Emma. Every day getting on my nerves. Emma. Oh, I'm begging you. Emma. Leave me alone.
Do we have any more case presentations, Arun?
I have
more. Yes, go ahead. Go ahead, please.
Sharing, yeah.
Yes, please share your screen.
Yeah.
Dr. Ragani?
Yeah.
Please share your screen.
Yeah, is it visible?
Yes, good. Go ahead.
Go ahead, please.
A minute. Yeah. So I am working at a peripheral center with limited resources, and just a minute. Yeah. So this is the first case of 74-year-old male with a crescendo angina and presented with non-stable vision MI, and echo was suggestive of hypokinetic LAD territory. And we did an angio, and later we did an MRI. It was suggestive of viable myocardium in the LAD territory. And this was the angiogram. It was suggestive of a left man was looking like diffuse disease. The LAD was very small vessel disease from the ostium, and the circumflex was also quite a significant disease in the mid segment. And this was the cranial view, where we can see a chronic total occlusion after a diagonal branch that is also a diffuse disease. So this is a diffuse disease vessel with a chronic total occlusion, and the RCA was also diseased, and there was a retrograde filling LAD, which was a small vessel, not a very big vessel. And this was referred to surgeons, but they refused because of the bad targets. And the patient was kept on medical management, but because of the persistent angina, we have to take him into the lab. And this was the starting of the case. We took guiding EBU with a retrograde injection, and we just first thought it's a tight lesion, so let's see how the collaterals coming up, and try to negotiate into the. But with the workhorse wire, that was Renato, we could able to cross into the true channel, and I took a microcatheter, and just I went into the LAD and took a very small shoot with a 2 ml syringe, whether how is the target vessels, where to go ahead, and I made sure that I am into the true lumen in the different views, and I was into the true lumen, and then I dilated with a 1.5 millimeter balloon, and this was after dilatation of the proximal segments.
the vessel size was not very good. I don't have imaging with me, so I dilate with the 2 millimeter balloon to 15, and after dilatation, I could feel my balloon is having a feel of calcium there, and on fluoroscopy I can see the ostial LED was calcified and fibrotic lesion. It was not giving way even with a 2 millimeter balloon. So at that time I thought let to just bury it, because the vessel was not growing, and there you can see the eccentric intimal and medial calcification there, not very much adventitial calcification. So I changed over a microcatheter to the rota wire, did a few of the burring over the proximal to the mid LAD, and with the 1.5 millimeter burr, the vessel was not growing, though even after burring. And then I took a 2.5 millimeter balloon. I had a gut feeling that the vessel size in the proximal osteosegment has to be big. And then I made a sizing balloon and took a long stent, around 33 millimeters ions stent, kept in the at the ostium of the vessel, and dilated it. And this was the result at the end of the case. I left the circumflex at that time because, and then fixed up the right coronary artery. And this was the right coronary artery, the collaterals had stopped, they're not filling up. So this was the first case I did. I would also like to show another case where a middle-aged male came with a chronic stable angina, not willing for surgery. The LAD was 100% and the circumflex was 90% occluded, and the leftman was of good size. RCA was normal, and this is the case. It was a true chronic total occlusion. I take a microcatheter with my workhorse wire. I try to see if I can find any channels, but I soon realized that it's a difficult case, and I went into with the filter XT to find any microchannels. And I could try to negotiate the wire till the mid LAD where I can see the vessel, and I kept on checking with the retrograde injections. And when I thought I'm not getting the microchannels, I changed my wire to the Gaia wire, and I thought let's do angulated and some drilling and try to get into the true lumen. But I was going into the subintimal space at the entry point, at the distal entry point, exit point, and this was I think Corsa is there. It was a case done around 6 to 8 months back, and with changing the direction of my wire, I kept on trying. I could go into the LAD, but in different angles again. My vessel was not looking into the at the tip of the LAD, so I think I went into some branch, and then in different angle again it was subintimal, and then I tried to go into the true lumen by penetration of the subintimal space, and then over wire I changed to the over microcatheter. I changed to the regular workhorse wire, and then I did balloon dilatation with a 1.5 followed by 2 millimeter balloon, and took a 2.5 millimeter stent. As soon as I stented my LAD, the patient developed chest pain, and I realized that at that time the circumflex was 100% occluded. Sorry. Is my screen visible?
You are visible, but your presentation is not visible. Please go to your presentation.
Your invitation is visible.
Okay. So then I suddenly stented the circumflex because the patient developed balloon and stented the circumflex. I think with my dye injection, with the shear stress, the circumflex plaque has given away, and it became 100%. And post dilatation was done with the circumflex artery, and this was the final result after stenting into the LAD and circumflex.
Dr. Ragani, we can't see your angiogram. We can see your invite email.
Just a minute, sir.
I think you might have to share a different screen. Share your presentation screen.
Yeah, just.
You guys want to initiate some of the discussion since we're kind of running short on time? Any comments? There we go. All right, get back.
So, yeah, I will just go it fast.
Sure, Neeraj. Thanks.
So I stented the mid LAD with a 2.5 long stent, and as soon as I stented the mid LAD, my circumflex got completely occluded, and patient developed angina and ST elevation in the lateral leads. So at that time, I realized that my circumflex occluded, and it did the balloon dilatation immediately. I took out the wire of the LAD and put it into the circumflex, because at that time the ST elevation was there and LAD was already stented, and I stented the circumflex then immediately and did a post dilatation of the circumflex. And this was the LAD, which was flowing nicely. This was the final shoot, and this was the circumflex. It was also flowing nicely. Though ostial LAD is also diseased, but this is what I could achieve without imaging. Thank you.
Great guy. Great cases, Dr. Neeraj. Any comments from the panel or the chairpersons?
So, Dr. Neeraj, what was the reason for occlusion of the circumflex?
I feel, I don't know, but I feel there was no embolism. But I feel when we take a shoot, shear stress on the artery sometimes can take the vessels, the other vessels. So I think that was a tight lesion and just got occluded.
Thrombus, you mean to say embolization of the thrombus?
No, there was no thrombus. There was a dissection of it.
Dissection of the plaque in the LAD.
One more question, please. Let's just have one more question or a point by any of the chairpersons, please.
Well, I think the circumflex occlusion, maybe that the circumflex was the acute lesion in this case. So that was the culprit lesion in the circumflex, thrombotic lesion, and with multiple injections probably that got a bit disturbed and maybe occluded, or that might be, but it doesn't look much relevant for the procedure. But it was done in a nice fashion. It was antegrade wire escalation case. The only observation is if you see if the antegrade wire escalation would have failed for alternative approaches, the retrograde collaterals were very close to the distal cap, and it would have been a difficult access retrogradely because there was not much purchase, and it was the retrograde collaterals were entering very. It looks like very close to the distal cap or even into the CTO segment. Obviously, we've not seen other views, but that might be one of the concerns once the retrograde approach will be used.
Well, do we have Dr. Arindam Pandey?
Good morning, everybody.
Yes, Dr. Pandey, share your screen.
So, thank you very much. So, this is my case.
Please go ahead.
So, my patient was a 57-year-old male who had class 3 angina, hypertensive, non-diabetic, ex-smoker. So, he was on 5 anti-angina medications, so very significant angina. Normal ejection fraction, echocardiography. So, we took him for coronary intervention. And this was the angiogram of right side. You can see the right coronary artery was totally occluded at the midpoint, probably with some bridging collaterals. And left side was almost normal, not much a problem. And there was a faint collateral from left side to the right coronary artery. So we decided to take him for intervention. Initially, we thought there might or might not be any microchannel, though we are sure there was not much of microchannel. Still, we took a Fielder XT. So we thought let us try to go through the bridging collateral as well if possible, but our strategy failed. So this Fielder XT failed, and we took a microcatheter, 5-cross microcatheter, and the Gaia second wire. And this is the Gaia second wire, you can see. And this wire made some progress, but it went into false lumen. This is the picture. You can clearly see the Gaia has gone into false lumen. So we took it back and renegotiated with some manipulation. Actually, we could find the true lumen, and this is it. The true lumen has been reached. But actually, up to this portion, it was all good. But problem started after this. At that point of time, we had across CTO 1.1 balloon. That was the narrowest caliber balloon available in our lab. We took that 1.1 across CTO balloon. Nic Nano was not available in the cell. So this balloon 1.1 could not cross the lesion. So we thought, let us increase the backup support, and we took a GuideZilla, mother and child extension. This is the GuideZilla. Initially, we started the procedure with AR guiding catheter, French femoral access. And on top of that, we took the GuideZilla backup support with same 1.1 across CTO balloon. But in spite of that, this was the situation. It did not cross the lesion. So we thought, let us inflate the balloon, whatever progress it has made. Then at this point, we thought, let us take help of anchoring balloon technique because there was a tonus branch available. But while trying that, our whole system came out. So we thought, let us go for a higher backup support catheter, and we took a AL guiding catheter and tried a tonus micro catheter with AL1. This is the tonus. In many of our past battle, tonus helped us in winning the situation. So we thought tonus will help, and this is the tonus. It made some progress. It went up to the mid portion of the CTO, but after that, we failed to make any progress with tonus micro catheter with the AL guiding catheter. And at this point, we thought, what else we can do? We called the family relatives, and we thought only option which is left there to use a rotablation. Though there was a risk of using rotablation in this situation, this is a situation where our wire crossed, but balloon was not crossing. But using in this situation rotablation, there is a risk that if we had make a star, that means true false true kind of situation, there could be a perforation, but we didn't have any other option. So we discussed with family relative and decided to go with a rotablation. Problem was that our microcatheter also did not cross the lesion, so there was a great guesswork. This is how we crossed the rota wire, and fortunately our rota wire crossed, and we took a 1.5 rota bar, and this is how it is working. And you can see with some, this has crossed the CTO segment. And after that, the procedure was much easier. This is immediately after rota. We can see the vessel, and probably nothing wrong has been made. And then we took initially 2 millimeter balloon. This is a 2 millimeter balloon. And then we gradually took a 2.5 millimeter balloon. And after 2.5 millimeter pre-dilatation, we took a 3 into 40 millimeter drug-eluting stent, a longer stent actually. And this is how we inflated, deployed the stent. And this was the immediate result after stenting. We post-dilated with 3.5 millimeter non-compliant balloon. And after serial post-dilatation, this was the result. And we can see this is the end result. We did not do any harm, and the patient landed up in a good end result, and his symptom all went off, and he's been good. So take-home message: patience is most important and most vital factor for successful CTO intervention. At the same time, motivation of the cath lab support staff is also very, very important, and step-by-step approach, as has been described in different textbook and different journals, should be followed. With that, probably we can be successful. Thank you very much.
Great problem solving, Dr. Pandey. Any comments from the chairperson?
Yeah, great case, Dr. Pandey. You went through the algorithm of balloon non-crossable lesion, that you increase the support with the GuideZilla, then you try to use the anchoring balloon, and you already started with the AL1 guide catheter. Those are all valid options. My only suggestion was that when you did the wire escalation, when Gaia 2 was not crossing and you thought it was subintimal, at that point I will, in terms of safety, I will just leave that wire there and come with another wire, because what happened, we were lucky enough to get into the true lumen at that point, because there is no scientific way to tell how to get into the true lumen from that point, just besides a guesswork and some kind of feel of the lesion. So I would just leave that wire there, because that gives you an opportunity to know where the true lumen lies in two orthogonal view, whether it's on the inside and outside. And you can take the same wire, similar wire, maybe Gaia 2, you might want to take Gaia 3 or CP more stiffer. So some people call it a parallel wire, but it's not quite a parallel wire. That gives you the second wire gives you a guidance in where you have to go, and sometimes it provides a contact support as well to facilitate the wire, direct the wire towards the true level. It's not quite like some people understand it as a false channel to true channel entry. It's not a false channel to true channel entry. Parallel wire is just once you've gone parallel, subintimal, you go to the area where it has started to go subintimal, and you try to keep the wire intimal. So parallel wire is basically intimal rather than intimal, subintimal, intimal. So that helps sometimes.
That was a great point, and I think you pretty much went through the algorithm as Dave said. You might also want to try something called balloon-assisted microdissection. You can go up to 1.5 balloon, rupture it. But I think this was great. I think no one's arguing this. It's a great final result. In the interest of time, I'm going to move on to Dr. Pratap's talk, and then we could have the discussion whatever time is left.
Thank you. Thank you very much.
Great job, guys.
Next is my presentation.
Yes, sir.
You are on, Pratap.
Yeah.
Your show.
Okay.
So you have to share your screen.
I have shared everything.
Yes, we can see now.
Okay. I will just
Okay, guys, there are also a couple of questions at the very end that some of the users have asked. So would like to have a realistic check on how much time we have and how much time do we have for Dr. Pratap's talk.
I will finish in 10 minutes. Okay, can I start?
Yes,
yeah,
please.
Go ahead. Actually, I'm just telling how to do a simple retrograde intervention. If an antegrade approach is applied, entry to the CTO is difficult to identify and exit to the wire is pinpoint. So that time the retrograde approach comes. So the entry of the CTO is easy to identify and exit has a large exit to come. So you have a lot of things and you should have a dual axis essential. You may land up in a single axis if you do a homocollaterals, and most of the time you require a 7 French or 8 French in femoral and 7 French and 6 French in radial. This is actually a situation you should have bilateral catheter for the intervention. You can use a single catheter like this. If you take a large PDA or OM and just coming to the CTO proximal, you can land up with a single catheter intervention also. Heparin is the preferred choice and avoid LMWH as well as glycoprotein 2B3A. Always keep an ACT more than 300 and preferably 350. And a long cine with a bilateral injection is a must, and distal vessel to be very well seen. Like this, you should have a clear visualization of the vessel. That's very, very important so that you can see everything perfectly and including the collaterals. You have homocollateral or heterocollateral, but you have to see the projection. Septals are the best, and it is the safest and choice by default. You should look into the tortuosity and you should have a straight, faintest collateral, and that is the first choice for retrograde intervention. Usually, when you go from the right coronary artery to the left system, you may see that like a V-shaped turn of the curve and areocranial projection. That's ideal way of entry. You should have two angles. One is an areocranial and areocaudal. And areocaudal is important to inadequate the check anatomy. A rotational angiogram is important. When you just go like this, this is actually the septal channel is an example 1. You have an example 2 like this. You have the septal channel very well seen. This is actually the septal channel coming up, and you should check the septal channel. You are just entering, and you can see that the septal channel coming out. It is not in the right plot. I just moved back, moved back, moved back. This is actually like a surfing technique. When I entered, it will easily going into the left side. That is the way it should be going. And this is actually the finishing the procedure. If you actually can have a right coronary artery to the left system and going and reaching there, epicardial collateral, you should have length, tortuosity, and size is important. Adequate size is a criteria. Tortuosity is always will be there in epicardial. And you have a very, very important thing is actually collateral rupture is dangerous in epicardial collateral. These are the epicardial collaterals. You can see an example 1 and we have an example 2. We are entering to the epicardial collateral, just checking. I think you can see that the epicardial collateral going inside and reaching to the opposite side and finish the case. There's another one. This epicardial collateral from LAD to diagonal to OM, and we are finishing the case like that. So epicardial can be atrial channels, PL channels, and apical channels. You should have always important that the favorable channels are the minimal tortuosity with adequate size, and extreme tortuosity is unfavorable even if the vessel looks very big. Bernal classification, everybody knows that actually the septal, very important point is tortuosity is the success determinant, epicardial size is a success determinant. When you go to the channel crossing, you require guide wire, you require microcatheter, and you require surfing, but the wires now use is cyan and filter XTR and SUGO3 for the epicardial collaterals. Cyan blue or cyan black is the septal channels are very well visualized and clearly and continuously. In XTR is used if the septal channels are not visualized continuously. SUGO3 for the epicardial collaterals. You require fine cross, corsair, or caravel, which is over 150 centimeter for retrograde. Collateral channel crossing, surfing with a guide wire or selective injection you can use. What is septal surfing and tip injection? Always septal surfing was interventional wire control. Septal surfing is always useful for saving time, but always the tip injection is important because tip injection is actually can avoid to minimize the chance of channel crossing, isolate the channel, reveal the channel anatomy, and estimate the possibility of crossing. This is an example of a tip injection. If you have a septal surfing is like this, you surf, actually there are two angles and septal surf like multiple surfing. This is actually septal surfing. Take the wire out, repeat checking. This is septal surfing. Other one, you just inject and identify the vessel. Surfing is a blind procedure. We never drive a car with closing eyes. Getting information, then target and shoot would be the best. Surfing is an option after failure of the target and shoot. You should actually look at two angles. What is angle A and angle B? Angle A more than acute angle more than 90 in A or B will be dangerous, and it will be very definitely a negative factor for channel crossing. Dissection of rupture is rarely caused. In this case, you may use a double lumen catheter, Crusade or Sasuke for entering the vessel. Key to channel crossing, do not imagine smooth and quick navigation in tortuous channels through hydrophilic coating wires. Happen to negotiate those automatically, but not under perfect wire control. Take a step-by-step approach for safely crossing the channel and improving the success rate. Key to crossing success channel crossing are wire selection, optimal visualization, and strategy, not the operator's hand. Collateral channel in epicardial crossing, you may require SUGO3. You can use even a filter XTR or cyan black, which I use usually. Guide wire, the crossing the CTO number one is guide wire, second is a microcatheter, and see microcatheter, the first strategy in retrograde wire crossing is actually you require understand that retrograde procedures are by two mechanisms. One is a wire crossing alone. You require retrograde wire crossing or kissing wire. Direction of the antegrade wire crossing is antegrade is called kissing wire. Direction of the wire crossing is retrograde wire crossing. You use a balloon, you have a reverse cart or some cart, where the balloon is used in the retrograde wire is called reverse cart. The wire is used in the antegrade wire is called cart. Basically, this is actually the kissing wire technique and retrograde wire. These are the four techniques which published by Smith in 2011. Retrograde channel cross, you have a retrograde wire cross or a kissing wire. If not possible, go to kissing wire or a cart or reverse cart. This is the kissing wire technique. You have a wire crossed, the wire is not crossed. We are actually taking the wire antegrade. I removed the wire from the antegrade and crossed retrograde. The wire crossed is antegrade, not retrograde. Here is a retrograde wire crossing. The wire is actually crossed retrograde in the CTO segment. It is one example. Second example is that your wire is crossed again. You can see the wire crossing. Here the wire is actually crossed. The last segment of, you can see the last angiogram down, your wire is crossed retrograde. The third example, again, the wire is crossed here, again, it is retrograde crossing. The catheter was not sitting properly. We took the antegrade wire and finally crossed inside. This is another example. Multiple example, we actually changed the wire from one wire to the other wire and third wire. This is actually Gaia's third cross the CTO. These are all just crossing without any balloon inflation. This is another example. So the reverse cut, actually, we have 4 wire scenarios in reverse cut. One is actually both are in the same plane, both are in different planes. Both are in the same plane means intima, intima, subintima, subintima. Different planes. One is in intima, other one is in subintima. So same space scenario, both wires in the true lumen, you are, if it is not successful, what is the, if unsuccessful, the wire crossing, what is to be done next? You can use an antegrade ballooning. Once you create a balloon inflation, then your entry will be easy. If you can use even a larger balloon to create a dissection and enter inside. This is an example of reverse cut balloon. Basically, when the wire is crossed, nothing is crossed. We take a balloon inflation, once a deflate and go inside. As the balloon deflates, the wire is also going inside. Another example, reverse cut, balloon inflation. You can see the retrograde wire coming down. The balloon is actually almost at the distal segment, the wire we are crossing. Once the balloon inflation, as the balloon deflate, the wire goes up. You can see that in the last segment, was the balloon deflates, the wire goes up. Then balloon inflate, and then balloon wire goes up. This is the way it's a reverse cut is done. So the same space scenario, both wires in subintima, the same principle like intima. You can use a larger balloon or a smaller balloon and finish it off. Different space scenario. One is the antegrade wire is in the lumen, retrograde in the subintima, then it is more difficult to join space. Aim is to get both wires in the same space, where the connecting space is important. The only way is actually balloon antegrade and attempted crossing into the true lumen with retrograde wire. Inflate the antegrade balloon and attempt wire into the subintima, more reverse cut distally. So different space. This is the last part. And actually the proximal antegrade is in the subintima, retrograde in the true lumen. This is the toughest of the total 4 systems. The proximal cap can be very tough and same goal of same wire space. So antegrade balloon will never help in this case. The helping things are, this is the only situation antegrade ballooning will never help. Where the only 2 choices, one is actually change of the retrograde wire. You can use a stiff wire, a confianza pro in the retrograde system, or a knuckle the pilot 200 in the retrograde system to make a subintimal entry. Or the second solution is actually a guideliner or stenting is the other choice. Here actually the wire is not crossed. Antegrade intervention attempted, failed. Dissection in the proximal segment, antegrade wire in the subintima, retrograde wire is not able to cross. We tried with multiple wires. We tried every wire, including finally the wire crossed with the Congress Pro 12. Congress Pro 12 cries, it is a single catheter retrograde C2 intervention. So finally the Congress Pro 12 entered the segment. This is actually a different segment. We are actually recrossed antegrade, subintima, retrograde. We used a guideliner to enter inside. This is actually a guideliner entry. You can see with the help of a guideliner, we entered inside. Next is actually externalization. Retrograde wire crossed the CTO, wire is in the proximal true lumen, corset pushed into the antegrade catheter. Guide wire should be very long. It can use a Whisper 300, Philref C300, which was available earlier time. Now you have an RG3 wire to use. Exchange the short guide for a long wire or snaring the wire. Antegrade wire pass through the CTO segment, then do the intervention. Externalized wire brings tension in the coronaries. Extreme care should be taken. Avoid deep seating of the retrograde catheter. Avoid unintentional advancement of the retrograde catheter to avoid donor vessel dissection. And 6 French retrograde catheter, reduce dissection. These are all actually snaring technique, externalization, wire with a microcatheter. This is actually one technique. I just be fast because the time is not there. This is actually with the retrograde wire we are entering inside. You have a microcatheter inside, you have a guideliner inside, and then with that we entered inside. Now open the occlusion. First withdraw the corsair into the distal part of the thing. Rapid exchange balloon is centered, ballooning and stenting over the externalized wire or stenting over the antegrade wire. Removal of the corsair. Assess the potential collateral damage. Contrast staining in the septum is infrequent and seldom leads to hemodynamic compromise, but assess the donor artery patency is very important. And final assessment of the antegrade injection is also very important in this case. So the things to remember, it should be always an elective procedure, no ad hoc. Dual catheters are required in most cases. Specialized wires and devices are required for CTO intervention. Complications are more than routine in routine PCI. Success varies, depends upon the skill of the operator, availability of the device, attitude and perseverance of the operator. Always understand that these procedures have a failure rate of 10 to 50%, depends upon the above parameters. There is a learning curve for this. Proctor will be useful initially. Successful CTO has a long-term survival. Thank you.
That was a fantastic overview, Dr. Pratap. Guys, I think we are kind of extended our time limit. So apparently the next session is waiting. So thank you very, very much. I mean, feel free to message any of us on the panel or the chairpersons if you have questions. I'd like to bring this session to an end. Thank you, guys.
Thank you, everyone, and thanks. And have a good day.
Thank you, Arun. Excellent moderation and excellent.
Thank you, guys.
Thank you.
Sudhir, thank you.
Thank you, Pratap. Thank you, everyone. Great cases, and there were several good case discussions. Dr. Shetty, Dr. Gupta, thank you.
Everybody, thank you very much.
Thank you, Rastam. Thank you.
Thank you.
Good afternoon, everybody. So we will be starting with this session in next 2 minutes. We are waiting for the panelists to join.
I think till panelists are joining, let us hear from Dr. Adnan Kastrati about the COVID situation in Germany. Dr. Kastrati, good morning once again.
Good morning, Dr. Chandra. So the situation is better, is much better. So we have new infection cases under 1,000 per day now. And so active cases are between 10 and 15,000 only, although you see the numbers that are about 180,000, but it's the total number of infected cases that have been in this 2-3 months. But it's decreasing. It's decreasing, and the situation is relaxed now. We have no restrictions, practically, or self-restrictions, not obliged restrictions.
As compared to other European countries, Germany fared very well as compared to Spain, Italy, and UK. What you did right in Germany?
I don't know. I don't know what but the system is perfectly organized, I would say. So we took care in each hospital to be prepared for these situations. We had dedicated intensive care units, dedicated wards for COVID patients in each hospital. And we went down with the elective cases everywhere in order to leave availability for these critical situations. And so it's practically it's the effect of a well-organized system, I would say, because you cannot claim now that we have treated better the patients, because you have no specific treatment there. So it's the system that worked as a system better than in other countries, probably. But it's a good situation also in Austria, I can say. They have also very low fatality rate. And Switzerland is also doing very well. The number of infected cases is very low now. So it's in comparison with Italy, France, Spain, these are the countries that have done much better. But the reason for that is not known. It's not known. And you have also, we can mention the well-organized system in Germany, but if you see also some other countries, Greece, for example, or Balkan countries, they are doing also very well. Although you cannot pretend the same well-organized system, medical system, also for these countries. So it's also regionally dependent, and who knows?
So Pankwi, can we start? Pankwi, can we start now?
Yes, I think we can start. I would like to welcome Dr. Nishit Chandra as our moderator. He is the senior interventional.
फोन मिला कामेश्वर, मुझे तो कुछ नहीं पता चल रहा, ना इधर से पता चल रहा है पंकुरी.
ठीक है सर. Dr. Chandra, we can start.
Yeah, so good afternoon once again. Good afternoon, and thank you, Pankwi, for introducing me. And this is one of the most important sessions. Yeah, so good afternoon, everybody. And this is one of the most important session of our whole conference, because here we will be discussing how this pandemic has changed our lives and what is the way forward, how our cardiology practice is affected, how we should behave in our cath labs, how to protect our staff and patients. So all this will be shared through series of lectures by our learned speakers. So let me start by introducing my chairperson. I would request everybody to please mute their laptops, please, because that is interfering in our proceedings. So let me introduce our esteemed chairperson, Dr. Adnan Kastrati. You all know him. He's the head of the Interventional Cardiology at German Heart Center and the principal investigator for the ISAR series of lectures. Then second chairperson is Dr. K.K. Sethi. He is the chairperson of Delhi Heart and Lung Institute and a very, very senior teacher and mentor to many of us in our interventional practice. Welcome, Dr. Sethi, please. Our esteemed panelists are Dr. Kamaldeep Chawla. He's the head of the Department of Cardiology, Sterling Hospital, Vadodara. Dr. Kamaldeep, welcome. Dr. Animesh Mishra. He's the head of the Department of Cardiology from Negriham's Hospital, Shillong. Welcome, Dr. Animesh. Dr. Gajendra Goyal. He's an interventional cardiologist from QRG Hospital, Faridabad. Welcome, Gajendra.
Yes, thank you.
And Dr. R.R. Mantri, he's our colleague and senior interventional cardiologist from Sri Gangaram Hospital, New Delhi. So you can see our panelists are from all over the India. So it will be a very good discussion. So let me start by inviting our chairperson, Dr. Adnan Kastrati, to please start his lecture about the key lecture, the master's view. Dr. Kastrati, please.
Yeah, yes. Good afternoon, everybody. It's the third day that we are together in this activity. So what I'm telling you the next 10 minutes, it's about the European Society of Cardiology guidance, PCI in the context of the COVID-19 pandemic. So what was the rationale for the EEC guidelines regarding this topic? There was a need for tuning diagnostic and treatment algorithms of conventional patients with ACS.
Dr. Adnan, sorry to interrupt, but we are not able to see your presentation. Please stop sharing. Please stop sharing and click on share screen again.
And now?
Yeah, now we can see your presentation. Sir.
Okay. Okay. I'm sorry for that. So I was telling that the rationale for the guidance coming from the European Society of Cardiology was the need for tuning diagnostic and treatment algorithms of conventional patients with acute coronary syndromes to match with the situation created by the COVID-19 pandemic. There was a need for guidance on the use of coronary angiography for COVID-19 patients with suspected type 1 myocardial infarction. There was a need for adequate intra-institutional reorganization of cath labs and revision of pertinent SOPs. There was a need for adequate interinstitutional or intra-network reorganization of hub and spoke centers. What is the situation, the COVID-19 situation worldwide? So these are the data from yesterday, and you see that the total number of infected cases is more than 5 million. There have been about 340,000 fatalities due to COVID-19. And what is more concerning, you see here on the right side in the bottom, the numbers per day are increasing. So it's not that in every country is like this, but in total worldwide, there was an increase in the daily number of cases with COVID-19 pandemic. So what is the situation in Germany and India? Here is the curve of the cases in Germany. 180,000 cases so far infected from the SARS-CoV-2 virus. But you see that the curve has been declining, and we are now in a situation in which every day we have less than 1,000 new cases, infected cases. What is the situation in India? In total, there are 130,000 cases, infected cases in India, but the difference is that there is an increase in the daily cases in your country. So it's you see here that maybe it's a delay of 2 months regarding with respect to Germany in India. So what we had in March 22, you have now in May 22. So it's curious to see how this curve is developing the next days and weeks. What we know is that there is an age dependence of the risk of death in infected cases. Here in this graphic here, you see that the mortality is 2% above 50 years of age, but it goes up to almost 15% in cases above 80 years. And if you look in this other study here, published in JAMA, you see the age dependence in Italian patients. More than 80% of the cases were above 70-year-old. In China, it's the same trend, but the impact of the age is less evident than in Italy. So 50% of the cases are more than 70-year-old. So we all know how
लेकिन तुमसे कनेक्टेड है ना, तो फिर आवाज कैसे आएगी?
Pavan, please mute your Pavan. I would request you to mute your mic.
We all know that the virus uses the ACE2 receptor to enter the cells and to go for viral replication. This receptor is not only found in the lung, but also in the heart, in the vessels. So you expect a lot of damages also in the cardiovascular system through entering of the virus into the cells, but also the most important factor is the cytokine storm seen with the virus. So you see here that the vessels are damaged, microvascular dysfunction, macrovascular endothelial dysfunction, there is myocardial damage in the form of myocarditis, etc. This is a typical case with the chest CT here, the lung damage in these patients with COVID. And also you see the myocarditis in the MR and also the unspecific ECG changes in this patient. What are the diagnostic tests used for detecting the SARS-CoV-2 virus? So the most known and the most used test is PCR, which detects the genetic sequences of the virus. It is done taking nasopharyngeal swab or sputum swab, but it's a sputum also. But the most used test is done with the nasopharyngeal swab. The problem with this test is that it needs time. In our center, for example, you need 6 to 7 hours to have the result of the test, so that patients coming afternoon, so you can get the test result only the next day. There are also antibody-based immunoassays, so based on the antibodies against the virus, IgM and IgG. The difference between them is that IgM is 3 to 5 days post-onset of the infection, and IgG antibodies are past the infection. There are antigen-based immunoassays.
Dr. Castrati,
also.
your mic is muted.
Oh, really? No?
No, sir, you're on. Please continue.
And now?
Yes, you're audible, sir. Please continue.
It's okay?
Yes, please continue.
So, so this is an interesting study published in Radiology. More than 1,000 patients. 1,014 of them had both CT and also PCR testing. And you see the results. Only half of the patients had both the test positive. 308 patients had a negative PCR test, but a positive computed tomography. And 21 patients had a positive PCR test, but a negative CT, and 105 patients had a negative test and a negative CT. So the guidelines of the European Society of Cardiology define the patient risk status in 4 categories: confirmed cases, a person with laboratory confirmations of the infection, irrespective of clinical signs and symptoms.
एक सेकंड म्यूट में मैं जा रहा हूं.
Okay. And the other extreme is negative cases. They have had 2 negative tests sequentially. So, and between them, there are probable and suspected cases, which are the most difficult case to solve during our routine work. So these are the protection levels recommended by the guidelines. Level 1 protection is by all patients who are not suspected and not as probable SARS-CoV-2 patients. Level 2 protection, which is in the case of patients who are suspected to have COVID-19. And you see here the differences between level 1 protection, which is just surgical mask, and for level 2 protection, you need N95 mask or FFP2 mask. And you see also the differences between the mask in the pore size, 2 micron for the normal, usual surgical mask, and very small, 0.3 for the FFP2 mask. But the highest level of protection is level 3 protection, which is assigned to all procedures with aerosol generation and nasopharyngeal swab, for example, endotracheal intubation, and in all patients who are suspected to have the COVID-19. And you see here what you need for this kind of protection. It is FFP3 mask, which is a little bit more sophisticated with very, very small pores, much smaller than the virus size itself. And also you need a full face protection in these cases. But I have to highlight here that also it's done in our cath lab. All patients entering the cath lab should wear a surgical mask independently of the level of suspicion they show regarding COVID-19. What is done for the diagnosis of cardiovascular conditions in COVID-19 patients? Clinical presentation, chest pain and breathlessness is a frequent symptom in this kind of patients. Chronic and acute coronary syndrome presentation can be associated also with the respiratory symptoms. ECG, you cannot expect specific ECG changes in SARS-CoV-2 infection. The same ECG diagnostic criteria for cardiac conditions apply in patients affected by the infection and in the general population. It's a lot of discussions about biomarkers. A lot of patients with COVID-19 present also with elevation of troponin, but fortunately, these elevations are not very high, so they are mostly under 2-3 times the upper limit of normal, and they don't require any specific investigation. You see here in this slide that the elevation of troponin in patients with COVID-19 is happening after 10-15 days after the infection. And most of the cases, as I said, it's under 5 times the upper limit of normal. But in those cases which go above this limit, you have to exclude the presence of myocardial infarction. But it might be also related to myocarditis, Takotsubo, and shock situations that accompany this kind of pandemic. Non-invasive imaging. So the guidelines say that you should not perform routine cardiac imaging in patients with suspected or confirmed COVID-19. You should prevent contamination from patients to other patients, to imagers and imaging equipment. You should perform imaging studies in patients with suspected or confirmed only if the management is likely to be impacted by imaging results, and the imaging protocol should be kept as short as possible, also to prevent the contamination. Non-urgent or elective examinations should be postponed until COVID-19 infection has ceased. Categorization of emergency, urgency of invasive procedures during COVID-19, and the rationale is to increase the capacity for COVID-19 patients, to reduce exposure of patients and relatives to the hospital-related risk of COVID-19, and to reduce the exposure of healthcare providers to asymptomatic COVID-19 patients. So these are the categories given in the guidelines. Emergency, it means do not postpone the treatment of these patients. And in this category fall STEMI, non-ST segment acute coronary syndromes with very high risk, cardiogenic shock. Urgent category, perform, but within a few days, not immediately. Non-ST segment acute coronary syndromes of intermediate risk, unstable angina, left main PCI, and all the other categories here that are that fall in this category. Lower priority, it means that you should perform this within 3 months, but not urgently, not emergently. Advanced coronary artery disease with angina class 3 or New York Heart Association class 3 symptoms. Staged PCI in the case of STEMI patients with non-culprit lesions, and proximal NAD PCI. And elective are all cases that may be postponed after 3 months. If we look at the other procedures regarding valvular heart disease, emergency, it means do not postpone. It's balloon valvular angioplasty for patients in highly selected decompensated patients, is surgery in aortic dissection, and valve repair replacement for acute failing native or prosthetic valve causing shock. Urgent cases are those who should be performed within a few days. TAVI in patients with decompensated aortic stenosis, mitral clipping in also decompensated cases, etc. And all the other procedures have a lower priority. That means that they might be performed within 3 months or even after 3 months. Another category that need an emergency procedure is also the category of patients needing mechanical circulatory support for cardiogenic shock. So what about the cases with STEMI? So you know that there are two kinds of presentations of patients with STEMI. The one is STEMI coming through the STEMI patient coming through the STEMI network with the ambulance, and they are transported to hospitals with 24/7 service, cath lab service. And the guidelines say that if you assume that there will be a delay to PCI more than 60 minutes caused by the COVID-19 pandemic, you should use fibrinolysis. I must say here that here, at least in Germany, there was no situation in which we had to recur to thrombolysis in patients with STEMI. Here is the other scenario for self-presenting patients. If they go to hospitals with cath lab service, they have to undergo primary PCI. If they reach hospitals without cath lab service, then also here you should consider if the delay is more than 60 minutes related to the COVID-19 situation. And in this case, you may use the fibrinolysis according to the guidelines. What about the non-ST segment elevation, acute coronary syndromes during the COVID-19 pandemic? So there are the known categories, very high risk patients. Those, according to guidelines, need to be treated within 2 hours, and they follow the path of the STEMI patients. And in the other cases, high risk patients that need to be treated within 24 hours or later, in all these cases, the guidelines recommend to have the test before sending the patients to the cath lab. Patients with out of hospital arrest and cardiogenic shock, all those who are not suspected to have COVID-19 infection, they should be treated normally. The other patients, suspected or positive patients, I should say that the guidelines say recommend to be more restrictive with the use of mechanical circulatory support in this kind of patients. This is a recommendation about the interinstitutional or inter-network reorganization in the COVID-19 pandemic. So you have three kinds of hospital: non-COVID-19 hospital, which don't have a PCI service; COVID-19 hospital, which don't have PCI service; and COVID-19 hospitals with PCI service. And you see the movement of the patients. If the patient is coming to the non-COVID-19 hospital with no PCI service and they present cardiac emergency, they are all transferred to the hospital with PCI service. And those who has no cardiac emergency, they are transferred usually to the COVID-19 hospital without PCI service. And this is the relation between the two kinds of hospitals here. The COVID-19 hospital with PCI service may transfer COVID-19 patients who have no specific cardiac problems to the COVID-19 hospital without PCI service. This is to achieve or to ensure the best service to both kinds of patients, COVID-19 and cardiac patients. This is how the hospital is organized, and this is the case for our hospital. There is a separated triage facility, and we have an intensive care unit, dedicated intensive care unit for COVID-19 patients. We have the coronary care unit with two kinds of areas for COVID-19, in the case in which you could not exclude the COVID-19 infection, and COVID-19 clean area here. So depending on how the suspicion is, you can transfer the patient to this area or to this area here. If you look at the ward or CPU, chest pain unit organization, here also you have three areas. One area for proven COVID-19 patients, and the other two areas for suspected, and there is a COVID-19 clean area also. For the cath lab, we have only two areas. We have a cath lab dedicated to COVID-19 patients, irrespective of who are positive or suspected to be suspected or positive. And we have the other cath labs dedicated to COVID-19 clean patients. This is how we started with this triage here, and you see the tent here outside the hospital. All the patients are coming here, and they are interrogated about the possibility to have the COVID-19 infection. And now we have replaced this tent here with a container, which is more convenient and more comfortable for the patients and for the personnel. This is the entrance to the cath lab dedicated to suspected or positive COVID-19 patients. And this is my colleague working with a suspected case, having a need for emergency PCI. So at the end, I would highlight also one fact that is coming out from different countries for different institutions. So what we are seeing in the pandemic era is the fall in the number of acute myocardial infarction presentations. So as the cases with COVID are increasing, the cases with acute myocardial infarction are decreasing. And you see here the numbers 2019 and 2020, which shows a significant decrease in the number of presentations of acute myocardial infarctions. In our analysis, we have done also a large analysis with acute myocardial infarction patients. We see that this decrease involves not only patients with STEMI, non-STEMI, but also patients with cardiogenic shock. The reason for that is unclear. It is the reluctance of the patients to come to present to hospital due to the fear of getting the COVID-19 infection, or is the incidence decreasing in this case? I hope to be the second, and which may compensate for the excess in death cases related to the COVID-19 pandemic. Thank you very much for your attention.
Thank you, Dr. Kasrati, for a very exhaustive overview of diagnosis, triaging, management of this COVID, because everybody is learning. This is a new virus. We are learning from Chinese experiment. We are learning from Italian experience, and this was from Germany experience, a very exhaustive view. Let us ask Dr. K.K. Sethi, our esteemed chairperson, his views on COVID situation in India. Dr. Sethi, please. Please unmute, sir.
My name actually is coming in my son's
Yes.
name.
Slide, yes. It's unmuted.
Yeah, we can listen to you.
Okay. Now, I want to thank Dr. Adnani for a very nice presentation, but I have a couple of questions for him. Because we have faced tremendous difficulties in India actually in managing these patients, and I'll be speaking about some of these when I give a small presentation later. Given the sensitivity of the RT-PCR at about 70%, what do you think should be the gold standard for actually confirming the COVID-19 infection? This is a problem that we have been facing all the time, apart from the difficulty in getting the test done in itself.
Dr. Kasrati, you want to take that? Please unmute, sir.
Dr. Kasrati, you cannot hear. Can you hear me?
I didn't catch the very well because there was not a clean voice.
Can you hear me now?
Yes, please.
Okay, thank you. So, my question was that the sensitivity of the RT-PCR test worldwide has been reported to be about 70%. And as you have also shown, more CTs were positive as compared to the RT-PCR test. So what do you think should be the gold standard for of COVID-19? Are you missing 30% of the patients?
This is exactly the case. So if we look at the numbers we have now in our clinic, it's about 70% of the cases we had before. And so we are missing 30%. As I said, it is unclear. Because why it is unclear? I can understand the reluctance of the patients to come for patients, for example, with unstable angina, with non-STEMI, even for STEMI patients, but I cannot understand the decrease in the cases with cardiogenic shock, because this cannot be due to reluctance. So that there is some hope that in the COVID-19 situations, the incidence of acute myocardial infarctions or cardiogenic shock might be falling. There is more hope than reality in this, what I'm saying now. But so we cannot know the reason why the number of cases presenting with acute myocardial infarctions is decreasing in these days. No. Mostly probably due to reluctance of the patients, but might be other reasons also.
I think that has been a universal experience. Yeah. And we were quite intrigued by the acute fall in the number of acute myocardial infarctions coming to the emergency room. So one of my colleagues actually thought that it may be that they are having the symptoms, but they are scared and therefore they may be dying at home. Now, since in India, you know, the type of cremations that the bodies undergo after death are very well defined depending upon the religion of the people, he actually telephoned a very major cremation ground in Delhi, the largest cremation ground of Delhi, and spoke to those guys. And he was quite surprised by the information that the actual number of dead bodies received daily for cremation in that ground reduced to almost half of what was happening on a daily basis otherwise over the last several years. So that was quite an interesting and a surprising observation made by the staff of the cremation ground.
We should wait a little bit, because at the end, what will count is the total number of deaths seen in this period.
Yes.
And as compared to the to comparable periods of the last years. I think this is the most objective analysis of the situation. So now you cannot say, because you have also seen some data from Italy. In some regions, the mortality in this period is increased, very much increased. And in some areas, for example, in Rome, is decreased.
Yeah.
So it's at the end, you should do a country-based analysis for the whole year affected by the COVID-19 pandemic.
Yeah, there is a recent news item from Italy that the out-of-hospital cardiac arrests have gone up. They shot up. People are dying at home. They are not coming to the hospital. So thank you, Dr. Castrati. Thank you, Dr. Sethi. Now we should move to the next presenter. The next presenter is Dr. Pavan Sharma. He's a senior interventional cardiologist at Fortis Hospital, Noida. And he will be sharing his experiences of pharmaco-invasive approach in left main thrombus cases. Dr. Pavan, please start sharing your screen. Dr. Pavan, we are not able to see your screen.
I think there is some technical error with the sharing the screen.
So can we go to the next
participant, and in the meanwhile, we can sort it out.
Are you able to hear me, sir?
Yeah, Pavan, we are able to hear you, but we cannot see your screen. So if you are taking time, we can move to the next presenter. So I think we should move to Dr. D.K. Barua. And Dr. D.K. Barua is joining us from Vizag, Apollo Hospital. And he will be sharing his experience of real-time experience of patients.
We lost the audio.
So Dr. Barua. So I must invite Dr. Barua because there was some technical issue with Dr. Pavan Sharma's presentation. Dr. Barua is joining us from Apollo Hospital, Vizag, and he'll be sharing his real-time experience of patient management during COVID. So Dr. Barua, please share your screen. Dr. Barua, are you there? Yeah. Yes, we can see your case, Dr. Barua. Please carry on. You are not audible.
Please ask him to unmute himself.
He is unmuted. Dr. Barua, have you unmuted? Tech support, please see, since he has unmuted and still we are not able to listen. Dr. Barua? No, we can't listen.
Please remove your headphone. Dr. Barua, please remove your headphone and please speak. I think we lost Dr. Barua. Yeah, Dr. Barua is lost the connection.
Can we go to the next one, Dr.
Govind?
Dr. Biju Govind is there, or?
Yeah, I'm here. Can you hear me? Am I audible?
Yeah, Dr. Govind, we can't see you.
I know they have been telling the same issue. Can you hear me now?
Yeah, we can hear you.
I can see him and I can hear him also.
And probably you can't see my screen either, isn't it?
No, we
Start
cannot.
sharing your presentation. We can check.
That's, probably you'll have to give me also some time. I'm not able to. I asked for the tech help, but I'm waiting for them. Let me just try to put it once. Just give me a minute. If otherwise we, yeah. Can you see my screen now, please?
No, we cannot.
Oh.
These are the teething troubles of this new platform.
That's true. But we didn't have any problem last day, and even the morning I was surprised.
Dr. Govind, I think your internet is not stable. That's why we are getting the issue.
That could also be a reason, but then my screen should come in any case.
Yeah,
So I can see that my screen is not coming. Is what the
you click on share. You have to click on share screen option. Below the green button is there below.
Yeah, I can saw that. I did
click on it and click on desktop one. Yes, your internet connection is not stable. You are on mute, sir. You are on mute.
I'm getting is you cannot screen the share while the other participant is sharing. That is the message I'm getting.
No,
you
no
cannot
one is
start
sharing.
screen share while another participant is sharing.
No, no one is sharing nothing, sir. You can start.
Okay, then can you go to the next speaker, please? Meanwhile, I'm very sorry for
You can move
this.
to next presenter. By the time I'll arrange a call for you, sir.
So, Dr.
We have received
Ahmed.
Dr. Pawan Sharma's presentation. I can share it from my side, and in the meanwhile.
Yeah, that's great.
Yeah.
You can have my presentation. You're going to share, Dr. Govind.
Pankri, whose presentation are you sharing?
I'm sharing Dr. Pawan Sharma's presentation.
Right. So, Pawan, are you ready? Pawan, you unmute, please, and please start presenting. We can see your presentation loud and clear. Pawan?
Already, if Dr. Pawan is not there, my presentation is there with you. We can finish it off in the next 5 minutes quickly, Ms. Pankuri. I think you have my presentation there.
Sorry about that. Yesterday it went very smoothly. Today there are some problems. Yeah.
That's right.
So Pankuri, are you on the job?
Dr. Biju, you can share your presentation now.
No, you can. I can share it, or you are going to do it for me?
You can share it, sir.
I'm not able to share it. You have my presentation there. Why don't you do it for me? That will save our time also for all of us.
So Pankuri, are you sharing Dr. Biju's presentation?
I don't have Dr. Biju's presentation right now. I'm just managing it. In the meanwhile, can we do Dr. Pawan Sharma's presentation? Maybe I have it handy with me right now.
But Dr. Pawan is not there, I believe. He's not responding to it.
Here, sir.
Yeah, so Pawan, if you can start sharing your screen and we can listen to you also.
Dr. Pawan has to unmute himself first. Yeah.
Are you able to hear me?
Yes.
Yes. Okay, I can start now. Pankuri, could you start my presentation?
Yeah, Pawan, please start.
Yes. You can hear me, Nishit, sir?
Yeah, we can hear you very well, clearly.
Okay. Thanks a lot, sir. Thanks. I am Dr. Pawan Sharma from Fortis Healthcare, and I will be presenting a small case, just a small presentation. And as we have learned from some stalwarts, this is the era is again coming for the pharmaco approach and then invasive. This case was done before COVID, and this is invasive pharmaco approach, and it can lead us for some of the cases in this era also for some discussions. So next, please. The case was 40-year male, around 100 kg weight, and he presented with history of retrosternal angina-like pain of 6 to 7 hour duration in the night in emergency. ECG was suggestive of acute ST elevation anterior wall MI, and patient had ongoing chest pain. At that time, EF was 35%. So I thought that we should took it for primary PCI. Next, please. So these were some of the features. Basically, the patient has one thing that during angio, I will show the next angiogram also. You can go to the next slide. I will brief this slide during that time. Yes. And this was the angiogram, and that revealed the proximal LAD was 100% occluded. The LCX was flowing normally. The RCA was codominant, and it was also showing some minor plaques. So I thought that this is a simple case. We can do primary angioplasty and come out in a single time. But at the same time, when I gave the patient heparin around 100 unit per kg, the ACT measured was 125 only. I have to increase the dose of the ACT of the heparin, sorry, and then I have to give with the meanwhile it was reached to around 20, then 25 units, and the ACT was now not coming into the target range. It was around 180 after that. Next, please. Next slide. Yes. Before that, it would be better, or I can pursue with it. -1. So -1. Okay, if not, I wired the, sorry, I will go through this. Basically, I wired the LAD and then start thrombosuction. After the initial, a small chunk of thrombus came out, and there was some flow, which was obvious in previous slide before that. But after that, despite repeated thrombosuctions, nothing was coming out. And on the other side, patient developed increasing in pain, ST, and start collapsing with the vitals destabilizing. Fortunately, I had 2 wires at that time, so I wired it LCX within seconds, and then I thought that the viable Hello, could you hear me?
Yes, go ahead.
So you can run this slide. So I thought that the viable territory should be preserved because that is the better. So I go for the LCX, and I did thrombosuction repeated to the God saved me, and I was able to restore flow in LCX and some flow in. And then after LCX, I tried again with the thrombuster, with several thrombusters repeated for around 1 to in the sorry, I was able to catch the flow in the LCX, and then I thought what to do. I tried several balloons, but nothing was working. Please be patient. Don't change the slides in so hurry. Just the last one if possible. Yes. Then I decided at this point, less than -1 slide before this. Before this is important. Yes. I thought, yes, you can run this. Before this, if able. Then I decided that what to do at this particular time. It was around 2 hours, 2.5 hours after repeated thrombosuctions, nothing was working. Then I thought that best is to do thrombolysis intracoronary. There were 2 choices, either to go local into the LAD or go through the intracoronary catheter only. I thought that the LCX was also involved meanwhile. So better is to do intracoronary rather than going into the distal part. So I used 1/3 dose of tenecteplase and then thrombolized the patient on table. I was able to rescue patient without any IABP, without any ventilator. And then this is the check angio after 2 days. That showed that there was LCX was nice, RCA was good, and the LAD was showing flow with some diagonals flowing and septals flowing up to mid LAD, and the patient survived. After around 1 month, I did a CT angiogram of the patient that showed recanalized LAD, and at the same time, the PET was done to see for the viability. Unfortunately, the distal part was non-viable, akinetic. So I decided that I will keep the patient on medical management. I kept the patient for medical management for around 1 year. Next slide, please. Next slide. And this was check angiogram after 1 year. Last one. And that showed that the artery was, LAD was recanalized. The contractility was relatively preserved in LAD's area also. EF is around 40 to 45% now of patient. It is around 2.5 years to the patient. He is quite good, doing his work normally, and his follow-up. So to take home message is that we should be prepared. Any case may become nightmare for all the intervention cardiologists. We should have all our plans ready. And lastly, to say it is easy, don't panic. See for your plans. And if we are able to execute in some patient, then sometime God saves us. And these are different options which should be in our mind while dealing with and in COVID era also, the invasive options with pharmaco-invasive, if required to curtail the time, may be a solution. Thanks a lot.
So thank you, Pawan, for showing us the unique utilization of intracoronary thrombolysis. Though it's not come into guidelines, but we all have seen and bailed out time to time. Let's listen to Dr. Sethi that what is his opinion, because in COVID era, initially the reports coming from Wuhan was that there was a role of thrombolysis, but all the guidelines now, the ESC guidelines as well as the American guidelines now say that in STEMI, the primary PCI is the standard of choice, even in the COVID era. So, but in our logistics wise, the patient is not tested, he's suspected. In Indian settings, what is your take of thrombolizing these patients? Dr. Sethi, please.
See, this is a burning question actually, and if you would remember, the Cardiology Society of India actually issued some guidelines on 10th of April this year, and they also recommended the same based on the Chinese experience, which was published in European Heart Journal, saying that the first choice for therapy for these patients should be thrombolysis if they present with ST segment elevation, if there is a high index of suspicion of a COVID-19. However, subsequently, small series of patients actually were quickly published before and after the Cardiology Society of India guidelines came up, and I will show some of them in my talk briefly, where it was found that almost 35 to 40% of the patients with ST segment elevations do not have obstructive coronary artery disease, and their culprit lesion cannot be identified. Now, this is typical of what we have seen previously in patients who have myocardial infarctions related to influenza or pneumonia, where there is an intense inflammatory reaction, systemic inflammatory response syndrome, and you have myocardial injury. Now, obviously, when given in a non-obstructed, non-thrombotic lesion, thrombolysis can certainly cause trouble, especially if the patient has additional pericardial inflammation and all that. And that is why most societies have recommended that thrombolysis should not be the first choice. The first thing should be to perform an angiogram on the patient, make sure that the anatomy is right, taking all the precautions, using clinical criteria to suspect whether the patient is a COVID suspect or not. Because short of that, we don't have any other means. In our city as well as in our country, it is very difficult to get an immediate COVID test, and the reports are often delayed for more than 1 to 2 days, even with the best of your efforts.
Gajinder, what is your view? Gajinder, what is the view in Faridabad? How are you tackling it? Please unmute yourself. Are you thrombolizing or are you doing primary PCI?
Hello, I am audible?
Yeah.
Yeah. As such, for most of acute ST elevation MI, we are doing primary angioplasty here. Taking due with PP, with all the staff, with the cardiologist, with the staff nurse, with the technician. We are using PP kit with all the patients, STEMI patients. But usually in here, Faridabad, we are doing, I think we are doing less therapy, more primary PCI in our patients. But the thing is, I think one thing we need to understand in COVID, this era, we have to need differentiate between type 1 MI and type 2 myocardial infarction. This is important because we need not to be rushed in type 2 myocardial infarctions. Where patients may have myocardial infarction because of other conditions, like patient maybe because of COVID-19 also patient may have this type 2 myocardial infarction or other sepsis. In these patients, we are not rushing for the angiography and for the further procedures. Rather, with that patients who have a pure escalation and just short duration, this pain is there, no history of fever or other things are there. We are doing primary angioplasty in most of these patients.
Thank you, Gajinder. So, Pankuri, are we ready for the next presenter, Dr. Govind?
Yes, I think Dr. Biju Govind is ready. I can share his presentation.
Yeah. So, Dr. Govind, are you ready?
Yeah, I am ready. Can you hear me?
Yeah, we can hear you.
That's nice. I won't take much time. Can Ms. Pankuri put up my presentation?
So, Dr. Govind is coming from Guntur.
Thank you.
Andhra Pradesh.
Thank you, sir, for the invitation, and I hope we can quickly finish through this without any more technical glitches.
Yeah, please start. We can see your. Please unmute yourself. You are muted. No, you are still muted. I can see you are muted. The speaker is muted. We were listening to you earlier, but now we can see your slides, but your voice is not audible. Pankudi, please see why we are not able to.
He is again disconnected. We can move further if you want.
So whose is ready now? In the line list, we skipped Dr. Barua.
So we have some technical error with Dr. Biju Govind and Dr. Barua. We can start with Dr. Thabit Ahmed in the meanwhile. Dr. Ahmed, are you ready?
Dr. Ahmed?
Can you hear me, sir?
Yeah, Dr. Ahmed. Yeah, if you are ready, sorry for that technical glitch. But Dr. Ahmed is joining us from Baptist Hospital, Bangalore. He's a consultant interventional cardiologist.
Sir, I'm getting the same error message. You cannot start screen sharing while other participant is sharing.
So Dr. Biju has to, I think, unshare.
Yeah.
He has unshared, sir. You can try now.
Yeah, I'll try now. Can you see me? Can you see the presentation?
Not yet. We can see it now. Please go ahead before it vanishes. Capture.
One moment, sir. Just have to start it as a PowerPoint. So at the outset, I'd like to thank our chairperson, moderators, and the panelists. And Translumina. Am I audible?
Yeah, you are audible now.
Yeah. For giving me an opportunity to give a short presentation. So what I thought was, during this COVID era, with all the difficulties, I just thought 3 different types of cases to talk about in this short 10 minutes. One non-coronary, one coronary, and one coronary which we could not do much about. So once at the beginning of this COVID time, I got a call from a surgeon. He had a CA patient on chemotherapy. So he calls me. The patient had a chemo port in situ. So he tells me that the chemo port is not functioning. So he checked the X-ray. Then he realizes that the chemo port catheter has dislodged and gone into the right ventricle on the X-ray. So the first thought was, what do we do? I had taken my COVID leave initially. And do we leave this catheter in situ, put the patient on therapeutic anticoagulation? But it is not like a pacemaker lead which is screwed into the RV. This could have migrated to the PA also. But looking at the position, I doubted that. But I thought, at that point, we were not even having the protocol of initially testing throat swabs at the outset. But this patient had no history of travel, no history of any fever or any exposure to COVID suspect patients. So we thought we'll give a try for this. So I told the surgeon we'll try to snare it out. But it looked like a 7 French big catheter. So I thought I'll try to snare it out at least into the femoral vein. Then if I'm not able to pull it out, then you can do a venous cut down and extract it. And what was the thought was, should I do a IJV access or a femoral vein access? So I thought I would be more comfortable with femoral vein, but I was proven wrong otherwise after that. So I took a 14F ASD sheath, long sheath. I had used for ASD closure some time back. First, I tried a single snare, but the snare, for some reason, I could not snare it out initially with a single snare. Then I took a pigtail and a snare. First, I pulled the pigtail so that the catheter was slightly coming down. Then tried to snare it, but the catheter was snapping out from the pigtail. Then I tried 2 pigtails just to have a added grip, and I changed the direction of the catheter, pointing it towards the IVC. So that made it more favorable for me to do what I should do next. So actually, with every cardiac cycle, it started migrating more towards and lower down in the IVC. So immediately took a snare and snared out to the sheath. So this initially was I found it to be difficult. I mean, really, I have shown 3 videos, but then there were long time when I was trying to snare it out with 1 single snare, and then with the pigtail and a snare, and then 2 pigtails. Then finally it worked out. Next, I'll talk about a coronary case. So a 60-year-old lady comes to the ER in the early morning with the inferior wall MI, RV MI, and cardiac shock with complete heart block. So we didn't have time to assess other. This was a primary situation, and patient was in shock. But anyways, there was no history of fever or exposure to a COVID suspect. We took her up. The OM was a borderline lesion, circumflex was occluded. With the TPI and inotropic support, we went ahead and performed the angioplasty. There was some difficulty in delivering the stent because of the tortuous course. Once I opened up the artery with thrombus aspiration and early ballooning, thrombus was not going in easily with the proximal to mid ballooning. There was a very tortuous course. So I had to ambulatorise the JR catheter and push in the stent over there. Then I had to put 2 stents non-overlapping, leaving the mid segment of the RCA, which appeared non-involved, and I had not ballooned that segment also. Achieved a reasonable flow. Patient got discharged after 3 days. She came off TPI and all the inotropic support. Coming to a third case. Third case was a 79-year-old lady who presented to the ER with respiratory distress. So this is interesting. She comes with respiratory distress, but I'm not sure there was any fever. There was no fever as per the history. And I get called in after a few hours when the patient is shifted to the ICU. Now, in our hospital, we have a dedicated ICU for COVID suspects. Only the respiratory ICU. There are 2 ICUs, one in the ground and the one in the first floor, and another coronary care unit in another floor. So she was in the coronary suspect unit. And the X-ray was showing diffuse haziness in both the lung fields. So our intensivist was of the opinion that could be a COVID suspect. There was some vague history of fever 1 week back. But the ECG was showing very subtle ST elevation in 1 and AVL. Because it was a COVID suspect ward, the resident had called me, requested me to come and do an echo. He felt there was some regional wall motion abnormality. And the troponins had risen up to beyond 1000. So when I went and checked, there was postural wall, lateral wall hypokinesia and moderate eccentric mitral regurgitation. And patient was obviously in cardiogenic pulmonary edema. But considering COVID suspect, we had to wait for the throat swab to come, and patient was on a ventilator, being a 79-year-old lady, a little frail. So the intensivist also were not of the immediate opinion of trying to intervene. But subsequently, when the throat swab came negative, it was beyond 48 hours, and we counseled the patient relative. The relative was already like, patient is a little sick, so can we do medical management? So we just did medical management with double antiplatelets, and because it was already beyond 48 hours by the time that they really thought it was STEMI and not COVID. Patient has recovered. She was much better at the time of discharge. She's on follow-up. I have counseled them. She might need a coronary angiogram at a later date, but she is currently asymptomatic. So there's a quick 3 cases which I have spoken about.
So thank you, Dr. Tabit, for sharing 3 different scenarios. Any comments from Chairperson? Any comments from Dr. Sethi, Dr. Adnan, Rajender? So let's move to the next presenter. Pankuri, who is the next now, who's prepared with his slides? Next in line is Dr. Sujit Narayan, if he is ready. Or Dr. Biju Govind, if he has troubleshooted his technical glitch.
So Dr. Biju Govind is now available. I think I can share his presentation from my end.
So you can load Dr. Biju Govind's presentation.
Are you able to see it?
Yes.
Oh, nice. Can you hear me, please?
Yeah, we can hear you, Biju.
Oh, nice. Thank you, sir. Welcome to all of you. I'm sorry for those multiple technical glitches. I'm just going to present a small scenario. Most of it, the theory has already been nicely discussed and elucidated by Dr. Kasturati, so we need not spend much time. In our hospital, can you go to the next slide? I'm sorry, I will have to tell this every time because she's operating it. Next slide, please, Pankuri. So we have a dedicated COVID hospital. So our hospital actually is a private teaching hospital, has been taken over by the government. We have given 500 rooms to the government for COVID purposes. Currently, we have 200 plus patients positive and 100 plus on quarantine facilities in our hospital. We also have a 100-bedded ICU with 60 ventilator beds exclusively dedicated for COVID. So that's the basis on which I want to start it, but I will just put two short, small cases. Next slide, please. These are the two cases which we had in the initial time of our COVID experience. This was in the month of March, the second and third month of March, when we were not having many cases in our area. So the first was a 65-year-old male. This case was, he came with fever, cough, and breathlessness of 4 days duration. If I remember, it was somewhere between 15th and 20th of March. His chest X-ray was normal. He was tachypneic, but his saturations were maintained in room air. He was admitted as suspected COVID with early impending respiratory failure, whatever we call it, in the medical ICU as a possible COVID case. Next slide, please. His swab was sent for serology. It was very difficult at those times because the first and second week of March, we with the government agencies had to have multiple stumbling blocks to get the test done, but it was, the procedure was started. I mean, the process was started. Patient's ECG was normal. We didn't do an echo at the time of admission because we were not sure whether to contaminate the machine. Next slide, please. What to do? So he was managed in the medical ICU by the doctors with their whatever treatment protocol they were supposed to follow as per the guidelines at that time. That's the second, third week of March I'm talking about. On the third day, he complained he started desaturating. He needed a BiPAP. We used BiPAP then because, again, we were not sure how good or bad BiPAP was, how safe was BiPAP. Now we know it is not all that safe. But importantly, on the third day, the patient started having chest pain. Next slide, please. Yeah, this ECG showed typical ST elevation from V1 to V4. There's no argument. The echo was done at this time, showed regional wall motion abnormality. Next slide, please. We shifted the patient to the cath lab, knowing very well what we are dealing with. So we were quite well prepared with PPA on PPE before shifting the patient because we knew a 2-day. We were already prepared because it's a COVID hospital. Next slide, please, Ms. Pankaj. So in the cath lab, what we found is that this patient's mid-LAD was occluded, and we did a PCI. Next slide, please. We did not do a we did a thrombus aspiration. We gave tirofiban, and we could get a very good flow. This patient, of course, COVID did come positive later on. Next slide, please. This slide belongs, this case also, I don't have videos here because that makes our work easier. This case belongs to my colleague. This case was referred from the state COVID hospital. Now, how it works in Andhra is that we're the state COVID hospital, which is by the government, and all the district COVID hospitals, most of them are private teaching hospitals. So we got this, they don't have a cath lab in the state COVID center. So this patient was a 70-year-old, diagnosed positive COVID with multiple risk factors, had an acute onset pain in the right calf and foot with early discoloration. He was shifted. Next slide, please. We did a duplex scan, which showed a complete occlusion of popliteal artery. We did a peripheral angiogram, which showed, next slide, which shows a lot of clots in the popliteal artery with no flow antegrade. We did some penumbra device suction. Next slide, please. We did some lysis overnight. And then that is the flow which we got, as you see on the right side of the slide. So these are the two cases which I want to say, one with a coronary artery thrombus, another with a peripheral thrombus, both in the COVID positive scenario setup. So these are in the early period. So and as all of us have found out, subsequently our MI incidence have come down significantly. The next slide, please. The important thing is that ACE2, which is the enzyme which we know, which next slide, please, which the virus takes to go inside to the cell, is found everywhere in the heart as well. So no wonder that the heart is one of the organs which is affected, but it's also found in the intestinal epithelium. It is found in the vascular endothelium and the kidneys. So no wonder it is turning out to a multi-organ disease, with the predominant show being in the lungs, but other organs are also affected to varying degrees. Next slide, please. So I need not spend much time on these slides, if at all we have to discuss. So we know that there are various grades of presentation. Critical disease is less, but among the critical diseases, many of them have myocardial injury. Next slide, please. Have myocardial disease. 1/4 of them actually have myocardial disease. And we know the cause of myocardial disease. We talk about type 1 MI, type 2 MI. We know about the procoagulant effect, cytokine storm, all has been discussed in a long, next slide, please, has been discussed. So we need not spend much time on that. So next slide, please. So we can have arterial and venous thrombosis also. As we saw in our case, venous thrombosis is quite common. I heard about a colleague in a nearby hospital actually having a case which presented as pulmonary embolism, which was treated without no COVID status being known. Actually, patient had no fever, no travel history, no contact. So they treated as pulmonary embolism. Subsequently, COVID came as positive. So next slide, please. So presenting as pulmonary embolism is maybe a one-off presentation, but has to be kept in mind. So we have a whole gamut of presentations in the cardiac scenario. So we have to be, as time goes on in the next few months to maybe a year, God knows how long, we will have to deal with a gamut of conditions, as I told, acute myocarditis, cardiomyopathy, heart failure, non-STEMI, STEMI, arrhythmias, and sudden death. Next slide, please. So next slide, please. I will just, because Dr. Kastati has mentioned, I don't think there is any point in repeating, especially we are running late. So next slide, please. Just a few words about the management, about anticoagulation strategy and intervention strategy. The Mount Sinai COVID-19 anticoagulation regimen is available in the net, so we did not discuss this slide, but they have discussed on which situation to use heparin, when to use enoxaparin, and when to use apixaban. And most of my colleagues, next slide please, who I have spoken to abroad, says that they prefer these patients are on anticoagulation for 2 to 4 weeks after discharge. Hospitalized patients on anticoagulation, irrespective of whether they are on mechanical ventilation or not, do better if they are anticoagulated. So the survival rates are better for these patients. Next slide. Next slide, please. I've used this Jack article with Sky and ACC contributing to this article, and I've picked a few nuts from out of it and put in the next 4 or 5 slides before we conclude. Next slide, please. So this came in April, early April. So what is the all MI cases presenting to the ED should be screened, which we should do. All STEMI patients, they've changed since March, is that they should be all to be brought to the cath lab for primary PCI. Next slide, please. If you think the patient is likely to need to be intubated, it is preferable to do it outside in a center like in our hospital. We have kept a separate area where we keep these patients, and if we assume they are likely to need an intubation, of course we can't predict it 100%. We intubate the patient there before shifting the patient to the cath lab, and the room where they're intubated, there's only the people who are absolutely concerned with the procedure. We keep nobody else there. And we are in the process of procuring PAPRs. We don't have it as yet in our hospital, but hopefully most major cities and major hospitals in the country should be having PAPRs by now. Next slide. So what are the do's and don'ts? We have already discussed that. So avoid people hanging around, and avoid as much as possible intubation inside the cath lab. So that's okay, we will proceed. We will not spend time. The clarity is not quite good. Maybe it's my problem. Hopefully all of you can see the slides properly. Next slide, please. So the guidelines in the cath lab is There is a discussion now about having a negative pressure cath labs, but I do not know how feasible it is in our country and how many places can have it. With terminal cleaning would be the best thing to do. Otherwise, as a next step, we can even think about a HEPA filters in the cath lab, and whether we'll have to talk to our biomedical engineers, each of us will have to talk to our local people and people available to see how these filters can be adjusted can be fit into our cath lab. Next slide, please. Using a negative pressure cath lab looks a far-fetched dream, at least for people like us who are living here. Social distancing is what we have been hearing day in and day out. It's to be continued everywhere, including our cath lab. Only those people who are concerned should be inside. The CCL, the cath lab, huddles in the morning to discuss cases are a thing of the past now. We do everything online, all discussions online. Like we already have, I think most of the big institutes will be having online access to the cath lab videos, so recorded we can talk. Everything is online now. Next slide, please. Staffing rotation can be considered. We have enough people, like in our hospital, we have about 7 to 8 cardiologists, so we divide it into 2 groups. One group works Monday, Tuesday, Wednesday. The other group works Thursday, Friday, and the weekends, and then change across, so that to avoid all of us getting contaminated and having to go out of work suddenly. Important thing which I personally feel is that the donning training has to be given. And most of us may be good in doffing, but the donning technique of most of us, I don't include the people on the panel, but I'm talking about the regular practitioners, our students, all of them have to be proper donning training has to be given. In our hospital, we have a special training team to do as and when required. Next slide, please.
Dr. Govind, please come to the conclusion. We are running short.
Yeah, we will skip these slides. Next 2 slides we'll skip, and so all STEMI patients goes to the lab. Next slide. All NSTMI patients should be managed medically and they should not be shifted to the lab. Any delays should be documented. Next slide, please. So acute MI cardiogenic shock, we should be even more careful because the droplet spikes are more in these cases. Next slide, please. Next slide. So NSTMI, we are not going to take to the lab unless the patient has a very bad gray score, like more than 140. We'll skip the next slide. Next slide, please. We can go to the conclusion slide, the last one. Next slide, please. We'll just go to the last slide because I know we have run out of time. Next slide, please. Next slide. So this is the last slide which I want to keep. You can keep the next slide, the last one. Pankudi, the next slide, please. Yeah. So one thing is, the first thing which I realize is the 5 points which I want to take to my mind is that no one size fits all for all of us. What works here doesn't work in a tier 2 city, doesn't work in a metro. Everything works differently. The out-of-pocket expenses, the various schemes which are supporting also has been considered. Everybody must be there to help, but each one has to look after themselves. Only those people who are required should be inside the lab. And the last statement, which is most important probably, is the old adage which goes that a chain is only as strong as its weakest link. So we should try to protect each person concerned with the patient care in the hospital. Thank you very much. I'm sorry for skipping the time.
Thank you, Dr. Govind, and for illustrating 2 different non-atherosclerotic causes of thrombosis in COVID era. So we are running short of time. So we'll go straight to the next presenter. The next presenter is Dr. Sujit Narayan, the cath lab nightmare during COVID-19.
I think it's quite. We have very few COVID-19 dedicated hospitals with catheter lab facility in our country. So if you don't mind, I'd like to take a, we've lost. Hello, can you hear me?
Yeah, Dr. Sethi, please.
Yes, no, I would like to thank Dr. Govind for this presentation because he actually is working in a opportunity, having a very large hospital with almost 100 ICU beds dealing with COVID patients. So I have 2 questions for him. The first one is that since you have shown 2 patients with arterial thrombosis, and we know that there is as far as the American experience is concerned, there is a huge scare of venous thrombosis, which is actually a lot more than the arterial thrombosis. Do you have data on D-dimers in these 2 patients? Number 1. And my second question to you is, that since large number of COVID-19 patients are being helped to the hospital, how many of them have actually developed acute myocardial infarctions and with what symptoms? And that's a very critical data which I would have actually liked to hear from you.
Yeah, can you hear me, sir?
Yes.
Yeah. So to answer your first question first, regarding D-dimer, we don't have the data for both these patients because, as I told, this was early in the epidemic cycle, which we started getting these patients, and there was no guidelines worked out, and we had no idea how to go about it. So we did not do it because the government has restricted us to do, because this hospital was essentially taken over by the government of Andhra Pradesh. So we have to follow exactly the tests which they have advised and the medications they have advised. So we are not supposed to do anything more, anything less. But subsequently, since the second week of April, we started sending D-dimers, and most of the critical patients are getting D-dimers and putting more than all the patients in the ICU are on enoxaparin or otherwise. The other question, sir, was?
No, I was just wondering how many patients out of the last
acute MI. Yeah, we had chest pain wrong calls multiple times. Every time we go, we take an ECG, it's normal. We don't do anything more. So unless it's a florid MI in the ECG, then we do the echo and shift to the lab. So after these two, we had only 2 more cases in the whole month of April where we had to shift to the cath lab. In the month of May, we have not shifted even a single patient to the cath lab.
How many patients with COVID you had? Total.
We had a peak, we had 280 patients in this hospital. This is catering only to one district of Andhra Pradesh. So we have 258 was the peak we had. Currently, we are dealing 142 patients as of today.
So out of 280 patients, there are just 4 with suspected or proven myocardial infarctions.
Yes, myocardial infarction. We had pulmonary embolisms were there, but myocardial infarctions, we had only 4 diagnosed, proven. Yes.
Yeah.
So thank you, Dr. Govind. Thank you, Dr. Sethi. And now I can see my friend Dr. Sujit Narayan's slides. Sujit Narayan comes from Kailash Hospital, Greater Noida. And I'll appreciate Sujit to just come straight to the case because we are running very, very late.
Are you hearing, sir?
Yeah, Sujit, please. We can hear you and we can see your slides.
Yeah. Good afternoon, everybody. This is my small presentation about my practical experience about the risk stratification and precaution we have taken in my CCU and cath lab. In the initial stage of COVID era, during the lockdown, there was always a nightmare of all cardiologists what to do when the patient enter the emergency department with acute myocardial infarction in this with severe chest pain and hemodynamic instability. And second, other question was what will happen if patient found to be positive after procedure. Third, what to do if patient is COVID positive before the procedure. These were all the questions that come in the mind during this COVID era. It is always a question whether I am infected from COVID from patient or not after the procedure, even when we have taken all precautions. Risk of contacting infection by patient during procedure in a hospital. This is also a risk for the patient also. When you return from home after doing a procedure in a cath lab and meet your family in the evening, always come in mind whether you are doing right or wrong to coming to the home. Because there is a chance you can infect the family member also if you are infected with the patient. If you become infected, you will be quarantined for 14 days if you survive. If you know there are lots of guidelines for the management of ACS patient in COVID era. This is the Cardiology Society of India guidelines. They classify Group A, Group B, Group C already discussed. We all deal with Group C patient in our area. The patient has no symptom by clinical history, no history of travel contact with COVID-19 patient. But now because of the community spread in our society, we can't say whether it is belong to Group B or Group C. It may be Group A if test is not done. This is the strategy of MI already discussed, whether the Group A or B patient should be thrombolized or going directly to PTCA, or if the patient is of stable NSTEMI, then we do the PCI or PTCI after doing COVID test. If it is negative, if the patient become unstable in that period, we have to go for the primary PCI in this patient also, without waiting for the COVID result. Group C patient, that is resort to pre-COVID strategy, what we do earlier. This is the flow diagram. I'm not discussing it too much. Low risk patient, as this guideline shows, if it is a low risk patient, we consider for fibrinolytic therapy, then the transfer to the ward, do the COVID test. If it is negative, we can take it for the CAG and PCI. High risk patient, we can take the patient, we have to take the patient for primary PCI. If the patient is high risk, like anterior location, anterior wall MI, hypotension, class 3, 3, 4, cardiogenic shock, life-threatening arrhythmia is there, or delay presentation of more than, this is the guideline. Some of the procedures we do in the cath lab, we prefer to do it in the CCU now because of this COVID infection, like IBP, pericardiocentesis, extracorporeal membrane oxygenation, temporary pacemaker. Use always effective PPE for maximum protection and to prevent staph exposure, and perform PCI of the culprit vessel in primary PTCI always. So decrease the time of PCI in the cath lab. If you did not did the COVID test earlier. Some of the things we already discussed, we should avoid in the cath lab. Like if we think that the patient need intubation and ventilation at the time of PCI, primary PTCI, we can do in the CCU before going to cath lab. And if it is required that the intubation is required in the cath lab, then the all person not requiring during intubation should exit the room. Third is most important is CPR. When we do the CPR, we have to give pressure from above the mouth of the patient, so it should be avoided. So in this case, automated CPR device should be done. Guideline of COVID patient within the CCL. I have not got any COVID positive patient till now. There should be a single procedure room should be designed for care of COVID-19 patient. One cath lab should be dedicated for COVID patient. Airflow should be modified to negative pressure if possible. That is not possible.
Sujit, request you please come straight to your case.
Yeah.
We are running short of.
Yes, sir. Risk, preparation, and precaution. In this pandemic area, infection can reach the cath lab anytime and affect everyone, especially who had direct access, like with the operator and the cath lab staff. And also the patient is also, there is a chance of infection. It is essential and critical to be prepared in advance. We have to not to wait for the patient to arrive, COVID patient arrive, and then prepare ourselves. It will be a disaster. Today, the first priority in the safety of the team. If the team in quarantine means inability to save more patient. While time to revascularize remain a priority, patient outcome does not change, which if we take some extra time to take the history and clinical finding of the patient before taking into primary PCA. Room and teams need to be well prepared to receive positive or suspected COVID-19 patient by wearing personal protective equipment as given by guidelines like gloves, gown, goggles, shield, glasses. The first priority is to prepare each team before it. Cath lab staff have to obtain adequate protection equipment, should have the equipment, and should be trained to wear the PPE, especially removing the PPE, and regular clean and sanitize the lab after every procedure. At the same time, patients should be reassured about the safety of hospital with the area of COVID. Patients should be also reassured that our cath lab and CCU is protected from infection. Ideally, the dedicated cath lab should be located. For non-NSTEMI patient, timing should allow diagnostic testing of COVID infection by a positive pressure, by COVID RT-PCR test. And most importantly, if we do the procedure in the patient, that should be rapid discharge. Patient should be, as the patient is stable, discharge the patient from the hospital. to decrease the chance of contact with the infection. Transportation of suspected positive case patient is a guideline as given. We going there are two patients we get in the list last 1 week. One was 38-year-old male patient with coming emergency with severe chest pain, hypotension. It was normotensive, non-diabetic. ECG segment showed ST depression in the limb lead. Echo done at the bedside, so RWA with LVF 35%. X-ray was normal, shifted to CCU. As the patient shifted to CCU, had VTVF with cardiac arrest. CPR was given for 50 minutes, the patient revived, shifted to cath lab. CAG was done, it was normal, cardiac enzyme was read. The patient has persistent hypotension without any cause, aortic dissection, pulmonary embolism, everything was ruled out, and patient was put on IVP. Patient was died after 10 hours. It does not maintain the blood pressure. And COVID was done at that patient, one single test was negative. The patient was unexplained why the patient has severe chest pain and hypotension. This is the second patient, 72-year-old female, coming in emergency with syncope and hypotension. She was hypertensive and diabetic. ECG showed complete heart block of 30 per minute. Echo was normal. Blood investigation, all was normal. Chest X-ray was normal. TPI done. CAG non-critical. Persistent hypotension on maximum dose of hypotension on inotropes. No cause was found. After 1 day, patient regained his pressure. COVID test is awaited. Total procedure done in our setup after lockdown was 46. Total PCI I did 44. STEMI patient primary PCI 25. And NSTEMI and unstable angina elective PCI 19. And 2 pacemaker. All the patient was group C by history and clinical finding. And all patient was we consider as positive, COVID positive, and appropriate preventive measure was taken. COVID RT-PCR was sent to all patients after the procedure routinely. And we discharge the patient as early as possible. The patient is stable. Protective measures were taken as given in a guideline by operator and cath lab staff. AC of cath lab switch off during procedure. We keep the AC on for 24 hours in the cath lab. Before the procedure, we switch off the AC and we do the procedure as fast as possible, and then clean the cath lab and sanitize it. Culprit lesion are only done in the primary PCA, and if I do elective procedure, we pre-plan to decrease the time of the procedure. If the patient was found to be intubated, if there is a risk of intubation, we intubate the patient prior to the cath lab. And other procedure we can do in the CCU, we did the procedure in the CCU. Summarize, as the pandemic progress, we have to collect data about all the procedure and exposure in order to better our protection, because we don't know how much we are protected from the patient. If the COVID patient comes with a COVID positive and we did the PCI and we become the positive, then we can study what the protective measure we have taken. We have to keep the balance between benefit of the patient and our staff also. We have to balance all the benefit of both the person. Try to avoid elective care, not for us, but for patient to avoid exposure during hospital. We have to prevent the patient exposure also. And decision should be individualized, especially elective case, taking into account the risk of exposure versus risk of delay in procedure. Avoiding procedure always requires clinical judgment. If you think that the patient, we can avoid the procedure with the benefit of the patient, we can avoid it. If it clinically we have to judge that we delay the procedure, patient have the symptom, we have to take the patient in the cath lab. Some procedures which are life-threatening should be delayed, like a stable ischemic heart disease procedure in the CAG in this patient, endovascular intervention, device closure, EPS and RFA, or CRT. Drawback in doing rapid tests in ACR.
We are running short of time. Please conclude. Yeah, we are running short of time. Please, sorry to interrupt you.
So last thing is we can do the procedure in all the patient, whether it come in acute MI, unstable angina with hemodynamically instability. We should consider all the patients as COVID-19 positive and take all the precaution for the staff, operator, and the cath lab. Thank you, sir.
So thank you, Sujit. We have run out of time. We will straight away go to the next presenter. I think Dr. Barwa's slides are ready. So Dr. Barwa, if you can take, and I'll appreciate if you can stick to the time and come straight to the point, because we have overshot the time. It's already 2 p.m. Yeah, Dr. Barwa, please start. Dr. Barwa, you please unmute and start. We can see your slides. Please unmute. Yeah. Please start.
Thank you very much for giving me this opportunity. Next slide. As you know, this according to World Health Organization, viral disease continue to emerge and represent a serious issue to public health. In last 20 years, we have witnessed SARS-CoV in 2002 to 2003, H1N1 influenza 2009, again MERS coronavirus in 2012. Present pandemic is caused by what is COVID-19 is caused by SARS coronavirus 2, a beta coronavirus category. It has a round or elliptical and often pleomorphic form and a diameter of approximately 60 to 140 nanomicron. It is sensitive to ultraviolet rays and heat, can be effectively inactivated by lipid solvents like including ether, ethanol, chlorine containing disinfectant, peroxyacetic acid, and chloroform except for chlorhexidine. Next. Can you go to next slide? I think see. Yeah, as you know, there is various comorbid conditions can predispose to this COVID. You can say chronic liver disease, smoker, renal disease, immunocompromised patient, chronic lung disease, diabetes. All these are more prone for COVID, and even cardiovascular disease. You can see that 37% of the cases are cardiovascular disease. So any patient who has a cardiovascular disease, they are more prone for COVID infection. Next. As this has been already kind of shown in the previous talk, I just want to highlight here. You can see that COVID can get infected in various ways in the cardiovascular system. It can affect the endothelial cells, and it can develop coronary arteritis as well, and it can produce the plaque rupture and giving to type 1 kind of myocardial infarction. And another thing is that it can develop fulminant myocarditis, especially when there is a cytokine storm. At that time, when multi-organ failure, there will be severe cardiac acute shock kind of situation. It can produce myocarditis, leading to even heart failure. And there is myocardial, secondary to COVID, even myocardial stress and myocarditis, which can produce arrhythmia. So arrhythmia, heart failure, and acute myocardial infarction. These are the different. This can be different presentation of COVID infection in clinical practice. Next. And the management starts actually in the entry point. In our institution, we have a single entry point, that is the emergency department. We don't allow any patients to come in other way. All doors are closed. So right now, our entry is the emergency department, where emergency doctors will screen the cases, and this is all emergency cases as well as regular cases. We have same entry. And there, patient will be in the screen for temperature, history, cough, fever, and any travel or contact history. And they will be categorized as suspected COVID, highly suspected, or is a low category kind of COVID-19. Or if there is established COVID-19, then we can refer to our another unit, which is totally dedicated COVID unit. And cardiac cases we have seen, this time as ACS, STEMI, and heart failures. And at this point of time, we need to consider most important is the preserve the cardiac beds, hospital beds. It is very important, and as well as the healthcare workers. Preservation of the healthcare workers are very, very important. So we need to have a strategy to reduce the frontline. I mean, preserve the frontline workers as well as hospital bed. And it's always at this time it is reasonable to avoid elective procedures for like a stable CAD, endovascular the intervention, or any other structure like PFO, ESD, or even some EPS studies should be avoided at this point of time. Next. And in this situation, case decisions should be individualized, taking into account the risk of COVID-19 exposure versus the risk of delay in diagnosis or therapy. Fibrinolysis can be considered as an option for relatively stable patient with a STEMI with active COVID-19. In patient with active COVID-19 in whom primary PCI is to be performed, appropriate personal protective equipment should be worn, including gown, gloves, goggles, or any face shield or N95 mask. For most patients with a non-STEMI and suspected COVID-19, timing should be allowed for diagnosis for COVID prior to catheterization. Patients with COVID-19 or suspected COVID-19 require intubation should be intubated prior to arrival of the catheterization laboratory. That means threshold for intubation should be low in this kind of situation. Patient with suspected or known COVID-19 should be posted at the end of the working day if possible. And here is the patient in a primary PCI usually should be performed for unstable hemodynamic patient, and this is we take the policy of this is the patient. We reduce the number of staff in a primary patient. Normally, one sister should be there, one sister, one doctor, primary operator, assisted by sister, and one technicians. So we have reduced the number of personnel in the cath lab personnel so that we can preserve more people. And patients should be lying there. We use the all disposable protective kits. In a highly suspicious cases, although our hospital is not non-COVID hospital, but a lot of cases we have seen now coming as a COVID positive cases. So highly suspicious cases, usually we use the full protective PPE. In a case where this low category cases, still we use the kind of this PPE in the form of goggles, N95 mask, and all other precautions we take. Next. And this is also very important. Donning and doffing of the PPE is very, very important. And as you know, first day we need to wash our hand, use the cap, then mask, then put the dress fully. Then finally, you cover completely, and this is the donning of the whole PPE. And again, removal also very, very important. We need to remove first the initial mask, then cap, then mask, then the dress, and finally dress. And you need to know the different steps of removing the dress. This is also very, very important to understand during COVID stage. Next, please. This is one patient, actually a 57-year-old male, diabetic, presented acute severe dyspnea. In fact, he has a cough also. Initial stage, he was desaturated, orthopneic, hypotensive with bilateral trials. And ECG shows, you can see the ECG is a complete LVVB. X-ray shows bilateral fluffy opacity with some effusion, and troponin was positive. Is not very high, but it was positive. And this is the case. Actually, there is a high suspicion of COVID-19, and this is difficult to understand. Difficult to totally rule out COVID-19 at this stage. So here next. What we do, as you know, this RT-PCR, if we can do it, but it takes time, and plus, as we have discussed before, it is about 70% of the time it is positive. And in fact, in our state, we have a regulated kits. We cannot get directly, do the test. We'll have to send to the government hospital. They will do the test. It takes about 2 to 3 days time to get the report. So RT-PCR is ruled out at this stage. If you can do it, also you get report after 3 to 4 days. And imaging is useful in this kind of situation because image is, especially when patient comes to the stage, later stage, like this kind of presentation, severe breathlessness, this kind of situation, imaging is very, very useful. You can see that imaging can help you. You can see this, you can have groundless appearances with round opacities in the lung field. Is a very characteristic of COVID. In fact, another presentation, you can see the peripheral and opacification. You can see that. And both lung fields you can get it, and this is called crazy paving with a different reticular pattern. You can see that different spikes are coming. This kind of presentation also very characteristic of COVID infection. In this our patient, you can see the lungs are relatively free. There is only vascular cirrhosis. There is no parenchymal cirrhosis like this pictures. So this in a patient who is very sick, who is desaturated, I think this kind of HRCT picture can effectively rule out COVID-19 infection. So you feel more comfortable, you do the CT scan, find out, rule out COVID by scanning, then you can admit a patient in our ICC. Next. This is the patient, this is a kind of clinical situation what I am presenting. This is a 67-year-old male, diabetic, presented with acute STEMI, window period more than 12 hours. He was hemodynamic stable. Now question is that whether we should do these kind of cases for angiogram because patient is stable. So we thought maybe it is optional to go for kind of primary PCR at this stage because he is stable. So we admitted the patient thinking that we are not going to do as an emergency primary PCR because already patient is stable more than 12 hours. But subsequently you can see that he had pain. Actually, he started having post-MI pain and there is some dynamic change in the ECG. You can see this ECG and this ECG. There is the T inversion now again restarted. So this is the patient actually we need to do sometimes in this kind of situation. Although initially we thought is a stable patient, we will not do it. We will wait for some time. But during the hospital ICU stage, he developed the fresh changes in ECG with a post-MI angina. So in that case, we need to do this angiogram. You can see that the lesion, and finally we need to do stenting and patient recover. All these patients are done in last week actually. Previous patient, this patient. Next please. This is another situation.
Dr. Tarun, can you please conclude now?
Yeah, it is. This is the last slide. This is the third patient. Is the 32-year-old male, dyslipidemic, present acute MI. This is a kind of patient actually, who is acute MI with hypotension and continues to have angina. This is the kind of patient we immediately should do in spite of COVID situation. You can see that young patient who had a total occlusion LAD, finally primary was done in this kind of patient, and he is still there. I think tomorrow going to discharge. Next, please. So what is the take home here? COVID-19 is a evolving disease. We need to learn a lot of things from this disease. And one thing is we should understand is extremely contagious. Detection and prevention of transmission should be a priority for any hospital. Patient management should be based on the principle of risk of COVID-19 and benefit to the patient. Acute MI and heart failure can be first a presentation of COVID-19. And in all cases, guidelines for COVID-19 should be followed during interventional procedures. Thank you very much.
Thank you, Dr. Barua. Next presenter is Dr. Tarun Kumar, and he is basically presenting his real-life experience of managing acute MI from RML Hospital. RML Hospital, Delhi was one of the key COVID center from Delhi. So let's hear what his real-time experience was. I would appreciate if he sticks to time and comes straight to the point. Dr. Tarun Kumar, please unmute yourself. Yes. Please go ahead.
Yeah, good afternoon. First, I want to thank Translumina to giving me this opportunity. And this is like very difficult scenario and very difficult circumstances. And one kit cannot fit to all the patients. Like as many presenter, Dr. Biju Govind, especially explained in detail about all the COVID manifestations and COVID patient, and there are a lot of mimickers of acute MI in this current scenario. There are myocarditis, there are stress cardiomyopathy, there are other mimickers. So very difficult to differentiate between acute MI, true MI, and mimickers. But still, this is the first case. 43-year-old male, chest pain for 3 hours, interval MI, EF 40%, Focus echo was done, RWM in LED territory. Patient was thrombolized because patient was stable, chest pain duration was 3 hours. And next day, patient was intervened for angiography. This was the angiogram. Which was showing normal coronaries. We can analyze LED. As we can make out, it's normal, left main normal. As we can make out, LED was decanalized and RC was also normal. So this was the first case, and patient was discharged on day 3 with proper medical management. Now coming to second case was 66-year-old female, diabetes, hypertension, chest pain for 6 hours, Interval MI and ECG was normal. There was no complaint, patient was thrombolized, but patient has some relief in pain, but not all. Some 80% pain was still persisting, and ST elevation was also persisting. Patient was taken for rescue angioplasty. This was a left shot. If we can see, like the left main is normal, LED is showing some plaque, but L6 was not visible. Then we have taken the RCA shot. This was the RCA shot. In this, we can make out like L6 is also arising from right coronary sinus, and proximal RCA was having 99% blockage. So this was taken care of. BMW wire was passed, and it was like a routine angioplasty. Balloon dilatation was done. Then test was good. Achieving TB3 flow, patient was stabilized. 3 to 24 test was good, and this was the final result. TB3 flow in RCA, and patient was stabilized and shifted to CC. And this is the third case. 63-year-old male, diabetic, hypertension, chest pain from last 9 hours, CF class 2, Interval MI, patient was taken for primary PTCA. As I told, you cannot fit one approach to all the patients, you need to individualize, especially in this scenario. We can make out like LED is normal, L6 proximal 99% blockage, and retrograde filling of RC was there. Proximal RC was 100%. It was wire was passed. Normal wire BMW wire was passed and balloon dilated. And simple angioplasty was performed. Patient stabilized. His failure improved on next day, and a test was implanted. And this was the final result. And next day, patient was, although dyspnea was improved, chest X-ray was advised. This was the X-ray showing some fluffy opacity in bilateral lung fields. So like every patient in present scenario is COVID suspect. This patient was managed. Test RT-PCR was sent, but RT-PCR came twice negative. But still, as everybody knows, RT-PCR only can detect positivity in 70% of cases, 30% you cannot rule out. Every patient is a COVID suspect and COVID positive, all the patients to be managed accordingly. And you always approach like you should have PPE availability in your cath lab, manpower management, and patient selection. All things are equally important because you need to spare your manpower also. Your PPE availability should be there because one case positive comes, your cath lab will be shut down and everybody will be exposed. So prioritization of cases is what is the requirement. Thank you.
Thank you, Tarun, for being very quick and maintaining time. Just a quick question. Since you are coming from RML, what is your regime for HCQS? Are you doing it or?
Actually, there is conflicting data from across the world regarding HCQ prophylaxis. Like recent studies have come in which they found like patient who had started on HCQ treatment, it is not beneficial. But one recent study came from Mumbai in which they shown that like these persons who are on HCQ prophylaxis, they have not died. Instead, the person who are not on prophylaxis, they have died because of coronary COVID-19 other manifestations. So in RML, most of the people.
Yeah, Dr. Castrati, what is your take on HCQS controversy? In Germany, what are you giving it or not?
Say it again, please.
What is your strategy for hydroxychloroquine?
No, we are not giving it. No.
You're not giving
No,
it?
not at all. Not at all.
Dr. Sethi?
Yes, let me come in here. There is 7 days ago, there was a large data coming in from Mount Sinai Hospital. 5 weeks, April 7 to May 8. They have 1,400 confirmed COVID-19 patients with HCQS given. Survival rate is 27%. So they have not recommended use of this drug.
Dr. Biju, what is your practice?
Yes, we are giving HCQS as a routine for all patients. We are recording baseline ECG, but I don't think we are really bothered about QT prolongation. HCQS use alone without azithromycin. We are giving HCQS with whatever evidence we have or we don't have, but we have to follow the common guidelines because that's the rule that goes here.
So,
all our patients are on HCQS. If you ask for prophylaxis, we are not taking
the next case, Dr. Pavan Suri. Are you ready with your presentation? Dr. Pavan Suri is a senior interventional cardiologist from Jalandhar. Pavan, please share your screen. And we'll see whether you can finish in your allotted time. Dr. Pavan, we have lost you.
Am I visible, sir?
Yes, please share your screen. Yeah.
Is it visible, sir?
Yes, go ahead.
Thank you. Good afternoon, respected chairpersons and panelists. I feel most of the discussion about the cardiac cath during the COVID-19 latest guidelines have already been discussed. As Namaste has become the new norm in the current era, I feel this attire, what you see in this presenting slide, is the same what we're going to do in the current era, and it will stay for a longer time. If we see to the COVID-19, I just want to. You are seeing my slides, sir?
Yeah, we are seeing.
So I have deliberately talked about the COVID-19 and cardiovascular health because, you know, in times before COVID, we were more concerned about the patients and we hardly used to take care of ourselves and our healthcare staff. So that's why I have included the topic as COVID-19 and the cardiovascular health, because our health is equally important as is the welfare of the patient. So it was in December 19 that a cluster of patients with pneumonia, they were found in Wuhan, and it was found that it was caused by the coronavirus. As Dr. Majid, an epidemiologist, has already worked on the influenza and the SARS, and ultimately he found that whatever the route the virus may enter through into the body, it is ultimately the cardiologist, it is ultimately the cardiovascular disease which is going to be affected. So we maybe compute other sections of the medicine, the cardiology has only a marginal role in the fight against COVID-19. Nevertheless, the cardiologists are potentially involved in this story in at least 3 ways. So the 3 ways are, one is a number of cardiovascular diseases may increase the mortality among the affected patients. So a patient having already a cardiovascular disease, the mortality is going to be higher, as we have seen in number of studies also, the data which has been coming from the other countries as well. The second way how we can be involved is the viral infection could be the cause, or it can be the contributory cause of a new heart disease. We have seen few cases where there were thrombotic occlusions of the arteries and the veins, and this may be a association with the viral pathology, or it can be the contributory cause for these formations. And third is the drugs for the patients with cardiovascular disease could interfere with the pathophysiology of COVID-19. There was a controversy about the ACE inhibitors, ARBs. So these are the three ways by which the cardiologists are potentially involved in this story. So what the COVID has, we have a lot of case presentations, the complications and handling of various complications, imaging modalities. The COVID-19 has nothing to do with the technical part of what we are doing. What it has actually done, or it is actually doing, is our approach has changed, and it has to be changed for the welfare of this society. So what has happened is that the patient selection is very important in the current times. It is not that we find the patient of an ST elevation MI and straightway would take the patient in the cath lab and do the procedures. But the patient selection is very important. And over time, what I have realized in the last couple of months is that it is not only the ECG which is important, it is the saturation of the patient which is important, and the X-ray has got an importance. So the ST elevation MI patient with severe pneumonia, and it is better to have a conservative management, which could include the fibrinolytic therapy. The non-ST elevation MI with low risk features, they can be stabilized with the medical therapy. The troponin positive myocarditis without cardiogenic shock. The elective cardiac structure and the vascular diagnostic procedures, they can be taken for a hold for some time. And one of the panelists has already discussed about the type of the myocardial infarction. If we have a type 2 myocardial infarction or the myocardial injury with elevated troponin levels related to ARDS or sepsis, these are the subgroup of the patients which can be considered for the deferral procedures. At the same time, we should minimize our operators, our cath lab staff with these conditions, which like the patients have older age of more than 65, people with chronic cardiac disease, the pulmonary disease, the diabetes and hypertension. These are the risk profile of the patients which are more prone to have the complications once they are affected with the COVID. So this has already been discussed. This is the interim guidelines which has come up by collaboration with the SKY, EML and the Cardiology Society of India. They have divided into the group A, B and C. The group C is the negative ones, and group A and B almost have the same. Whether the COVID results have come positive or not, it doesn't matter, or if you have a high suspicion. And the second thing what COVID has taught us is that it has made us more of a clinical clinicians now. We have become more technically, we are technically very sound. We are improving on our technological skills, but we at any point of time we have been underassessing our clinical judgments. So this COVID has again got us to the basics, that it is the clinical judgment which is very important, and we have to rely upon the clinics, because in our country we are not allowed to do the COVID testing on all the patients. So it's all the clinical suspicion. And the clinical suspicion is if the patient has a close contact, if the patient has a symptom of fever or it has a flu-like symptoms. So these are the soft pointers which can tell us that this patient belongs to group B, and you have to tackle the things differently. Again, group A and B have the same. If you have the non-ST elevation MI patients, it is better to, and you have a non-invasive approach, you feel the patient is hemodynamically stable, you can just wait for the time till this tide is over and then do an intervention or do the invasive strategies in this group of patients. So this is again showing the same thing, the group A, group B and group C patients, and you have an ongoing symptoms, the hemodynamic compromising patients or hemodynamically unstable and the malignant arrhythmias. These are the group of patients in group A and B, where the PCI patients can be taken out for an intervention. So if we see for the general principles for the management of confirmed or suspected COVID-19 patients, all MI suspected or confirmed presenting to an emergency should be screened. So this is an added burden on an emergency where the screening should be done of every patient. All STEMI should be brought to cardiac cath lab for primary PCI. If the patient presents within 12 hours, one should take a chance of doing into the cath lab and doing the procedure. And if the patient, you need the bedside procedures like IBP, temporary venous pacing, it is better to do in the on the bedside of the patient rather than shifting the patients here and there, because by shifting the patients, you are exposing the healthcare worker and the staff also to the maximum, chance of contracting the infection is very high. So we have to use the effective protection device equipments for maximal protection and prevent the staff exposure, and perform PCI only in the culprit vessel. I feel in the cath lab over the last 2 months or 3 months, what we're doing, we are just trying to minimize the exposure of ourselves to the patients, and the patient and the operator exposure should be less. The quicker you do the procedure, the faster you do the procedure, open the culprit vessel, forget about the other vessels that can be tackled later on. So if we have to do the risk assessment, the inferior ST elevation MI or the lateral MI without the RV involvement, consider for the fibrinolytic therapy, consider for the pharmacoinvasive therapy. But if the patient is a high risk anterior MI, new bundle branch blocks, hypertension, clip class 3-4, cardiogenic shock, life-threatening arrhythmias, or delayed presentations, we are finding more of the patients presenting in this era, the delayed presentations. They are just neglecting just because they don't want to come to the hospital, or they are not understanding their symptoms. So we are finding more of the delayed patients, delayed presentations of the patients. So in that scenario, you can go for the rescue PCI or the primary PCI. So once the patient is in the cath lab, we have to take the appropriate precautions, use the appropriate PPE, frequently wipe down the commonly touched objects in the control room, like the keyboard. These are very, we don't pay much attention to these places, like the keyboards, the computers, the mouse, the door handles. These should be frequently wiped down with the solutions, whatever is available, whatever is the hospital protocol. The clean cell phones. The cell phones, everybody is carrying the cell phone, right from the patient to the doctors. So these cell phones can be the potential carriers. So we should clean these cell phones using 70% isopropyl alcohol wipes. All supplies that cannot be cleaned effectively at the end of each case should be removed. And the one more thing is that the social distancing. We talk about the social distancing in the marketplaces and grocery shops. I feel the social distancing in the hospital is also equally important. You can see this is me here, my colleague, the supporter is here. So we are just maintaining a social distancing in the cath lab, also trying our best to have less communication. So this is another thing, and we should try to do in the cath labs as of now. So if we come to the control measures, the dedicated specific rooms for the presumed and confirmed cases should be in the hospitals. The surgical mask should be worn by presumed or confirmed COVID-19 positive patients. Appropriate measures for mechanical ventilators and the resuscitation equipment should be carried out. We should carry out the deep cleaning and disinfection of cardiac cath lab after catheterization procedures for COVID patients. Reduce the number of persons who enter or exit the procedure room. Cover or remove all non-essential cath lab equipments in the procedure room prior to bringing the patient. If feasible, if the patient is stable and you want to take that COVID patient or suspected COVID patient, it's better to take the patient as a final procedure of the day so that the cleaning can be carried out effectively. Procedures which may be performed at the bedside in suspected or positive patients should be preferred, and the staff member responsible for the cleaning should wear the full PPEs. We should be more concerned and caring about the staff members, about the people who are cleaning, who are there in the cleaning, because they can also be the potential source for the infection. So we should equally care for them as well. So if we come to the guidelines regarding the PPE for the healthcare, this is going to be the new norm, right from the masks to the protective eyewears, full face shields, disposable caps, the gowns, gloves, shoe covers. In fact, we have been using all these before also, because once we do the HIV patients or the hepatitis patients, SCV or HBS antigen positive patients, we have been using these. But this virus is a different virus. I feel it does not respect the borders. It hasn't respected the international borders. It hasn't respected the state borders. It hasn't respected the departmental borders in the hospital. If we admit a patient in the cardiology, the neurologist is going to get affected. If we admit in the neurology, the cardiologist is going to get affected. So this is a different virus which does not respect the borders. So that's why we are coming out with the things that the maximum protection and of each and everybody involved in the hospital staff should be there. As my earlier speakers who have talked about these guidelines previously also while they were presenting their cases. So they in the cath lab, I have tried to avoid the intubations in the cath lab. So in the if a patient needs intubation, it is better to electively intubate the patient and then shift the patient to the cath lab. If the patient has to use the automated CPR devices, so avoid endotracheal intubation, avoid use of high flow nasal cannula and the ambuvax in the cath lab. So this is a couple of slides about our hospital. This is how we have tackled as of now, and we are complying with the guidelines. These are the two corners we have made outside our hospital entry. This is the flu screening corner, and this is the flu corner. And then this is our OPD. There's a glass shield we have kept between the consultant and the patient, and then we have divided our emergency into two parts, the emergency 1 and the emergency 2, so that there is no mixing of the patients, mixing of the COVID suspected and the non-COVID patients, because Italy health advisory had they have given their suggestion that the mistake what they did, that they were not able to differentiate or divide between the COVID and the non-COVID patients. So there was more of the mixing, and that's why more of the deaths. So we have tried to divide the emergency into two. So in this emergency 1, we are only dealing with the non-COVID patients. Here in emergency 2, we are dealing with the COVID and suspected or the positive patients. As of now, we are not being given, our hospital is not taking the COVID positive patients as per the government guidelines, but in coming times, I feel every hospital will have to accept their will have to accept these COVID patients. So we need to be ready for that. So this is how we have tackled as of now. And if we see to the real-time experiences, which was actually the topic of the session, the real-time experiences, and this is what, apart from there has been no change in the technical skills of the operator, there has been no change in the treatment of as far as the treatment part is concerned, but yes, our approach has changed, and this is what is the real-time experience. I feel that's why I didn't present any case here, because I don't feel COVID or non-COVID matters when you are dealing the patient in the cath lab, because when you are taking the patient in the cath lab, it is your responsibility to rescue the patient, whether his status is positive or his status is negative. So I feel the real-time experience is our approach towards the patient. So the pre-COVID, we were more concerned about the safety of the patient and the operator, but I feel now we are concerned about the safety of patient and the entire healthcare team. The patient safety measures were given the priority, but now the inter-patient safety measures. If we have a suspected patient, it is our duty to separate that patient from the rest of the patients in the CCU. We used to do the elective and emergency cases. Now we are doing a selective and high-risk emergencies. We were working with the entire staff. Now we have working with a limited staff. We have divided our department into two. We have divided the staff into two. So one is working with the one cardiologist and the other person is working with the other colleague. So in-person colleague counseling of the family used to be there. We are trying to avoid the family members counseling with the family via the telecommunications as far as we can do it. So we were flexible in disinfection, but nowadays you need to be stringent in disinfection after every case. Protection with normal sterile gowns used to be there. Now we are using the disposable PPE kits. Procedure was cost effective, added cost of the disposables. So another thing was the anxiety of the patient outcome. Whenever we used to go into the cath lab, we used to have an anxiety. Yes, we have to get the patient out of the crisis, irrespective of whatever time we spend, irrespective of whatever hazards we have, the professional hazards like radiation, other things. We were not bothered about that. The only focus was that the anxiety was that the patient outcome should be better. But now I feel the anxiety of the patient outcome plus fear of getting infected is there. So that is an add-on stress as far as I see to it. And then we had a good high workload, as our chairpersons have already said. The number of acute MI patients have decreased, maybe because it is very early to say what is the reason, but we have seen as there is a definite decrease in the number of acute MI patients. We used to have a very high workload, but the leisure time used to be there. But we as of now, we have the limited work, but you don't have the mind to have the leisure time. So the COVID-19 pandemic has started churning of the ocean. Though it may throw up some poison initially, it will end with benefits to the population. The only thing is that we need to be ready, and we have to be ready. Thank you very much.
So thank you, Dr. Suri. Your message was well taken that the technique of procedure remain the same as the protocols surrounding that, the safety protocols which needs to be taken care. A quick comment from Dr. Animesh Mishra, if he's listening, and then we'll proceed to the next. Dr. Rajendran. Dr. V. Rajendran is from Coimbatore. Please.
Yes,
Hello.
sir. Good afternoon. Are you able to hear me, sir?
Can you hear me, Dr. Nishit?
Yes, Dr. Animesh Mishra, if you can.
This is Dr. Sethi. Can you just give me a second?
Yeah, Dr. Sethi, please.
Actually, I have another commitment. We are quite late. So if you'd like to excuse me, I will try to take your leave. We are already, 40 minutes over time.
Dr. Sethi, if you can quickly present because we were waiting for your experience if Dr. Rajendran can excuse us.
Should I finish?
No problem, sir. No problem. Sir, can go ahead. No problem.
So Dr. Sethi, if you can start sharing, because we were waiting for your experience, it would be very beneficial for all of us.
Actually, I'll try to finish quickly because it's 2:45 and I have another commitment somewhere else. I'll get late otherwise.
I can understand, sir, but if you can take a few minutes, that will be more enlightening for us.
Hope the next presenter doesn't mind that.
Yeah, Dr. Rajendran has.
No problem, sir. No problem. No problem.
So Dr. Sethi is the chairman of Delhi Heart Lung and Institute.
How do we connect here now?
So just share the screen, sir.
I have done that. Now I put the slides on. Yeah, this one has to be closed. Can you see my slides?
Not yet.
So we need to see how to do it. Somebody has to guide us then.
You just go to the bottom green screen, share screen, bottom tab.
Yeah, this is what I did. Wait a minute. I have pressed share screen. Okay, should be somewhere here, isn't it? Where is the slide?
Pawan, have you unshared your screen?
So I think it might have to be copied. I have to copy it on the desktop. Only then it will happen. Okay, I'll need some time because it seems I'll have to copy the slides on the desktop.
Should we go to the next presenter?
You can.
Hello, so can you hear me? Sherry, sir, you can directly open your PPT and share.
No, I have opened it already, but
So you can go to share screen now on Zoom.
One moment now. What do I do now?
Go to Zoom. Click on share screen button, which is there on the bottom, green color button.
I did that earlier also. One moment. Stop this. Press.
Yes, we can see it now.
Yeah, please go to your presentation.
Go to the presentation, PowerPoint.
Yeah, just a moment.
Yes, we can see your slides.
You can? Okay, thank you very much. Now I just go through our real-time experiences during this period. And I really appreciate this opportunity of sharing our experiences with you. And I only hope that we would not have got that late, so we would have had some more time. Anyway, these are my colleagues, who have helped us a lot. As all of you know, that we are a non-COVID medium-sized facility. And it was not very easy to manage things when this whole episode started. The challenges that we faced during this time was the anxiety and fear in the staff and in the society. And there was a lot of reluctance among doctors and other staff to work. Protection and safety of the staff and patients was important. The news and the statistics were changing every day. And so were the media reports, and also some good and some bad information on the social media that added to a lot of confusion among the minds of people. So the result was that there was almost complete absence of inpatients from most hospitals, and the OPDs, etc., were, was rapidly started going down. So one of the first steps that we took in our organization was that I held a motivational meeting with the entire medical, paramedical, and non-medical staff and explained to them about the virus, what is the importance of protecting yourself, and how important it was for us as healthcare professionals to keep essential and emergency services going. After that, we created a multidisciplinary team, which was headed by our pulmonology and critical care people, but also involved our infection control team, including the microbiologists, internal medicine people, and ourselves. And we created a very robust patient and attendant screening protocol in the emergency room, which was regularly revised, on every maybe a week-to-week basis by a multidisciplinary team as we learned more and more about the disease and the symptoms with which it was presenting elsewhere. This is, if you'd like to see that, this is a questionnaire that we have prepared for both for the patient as well as for the patient's attendant. And this was prepared quite early, somewhere around mid-March, which looks at all the detailed history of the patient, including the travel history, the number of contacts that he has come with, national, international travel, etc., and the presence or absence of symptoms which can suggest a COVID infection. Then every patient undergoes a viral infection surveillance protocol, in which this table, we have a table that puts all these symptoms and physical signs in place, and a scoring system is there for each and every finding that we have. After that, the score is given to the patient, and the score of 0 to 7 is mild disease, mild score, and therefore this patient is considered a low risk patient, and the patient can be, decided upon as to where do we keep this patient. In the beginning, we were keeping these patients in the regular CCU because clinically they were extremely low suspect patients, and for us to get the testing done was virtually impossible because on the private labs there was no facility available. Moderate and severe patients, those who wanted to go to the ICU, at that time the guidelines by the government were that high suspect patients have to be tested and referred to a government facility. So most severe patients who came to the emergency, we referred them to the government facility, which was not very far from where we are. But unfortunately, they were so busy that it was virtually impossible to get an opinion, let alone a test done on the patient. Now, as the scenario unfolded, so did the opinions and guidelines from various situations. Now, of course, at present, it is very easy to talk because we have guidelines from various international societies, but most of the initial experiences came from countries that were overwhelmed with corona cases. One of the common thing that was there in all these experiences was that they all said that you should confirm a COVID infection within 60 to 90 minutes of arrival of the patient into the emergency room. And that is virtually impossible because not only that, this is just too little a time for us to do that, but the facilities for testing virtually did not exist in our country when this pandemic actually started. The first publication that I saw was the recommendations made by the Peking Union Medical College, which was published in European Heart Journal on April 6, which was based on the Chinese experience. And they said thrombolysis should be the default strategy in ST elevation infarctions, and the confirmed cases should be shifted to a COVID facility and managed there. Subsequently, we had the New York experience, in which data was shared from 6 hospitals in New York, came in New England Journal on April 17, where 18 cases of STEMI were recorded with COVID symptoms. And then on investigation, it was found that myocardial infarction with a thrombotic occlusion of the coronary artery was confirmed in only 8 of these 18, and the other 10 did not have obstructive coronary disease or a ruptured plaque or anything to suggest a localized occlusion of a coronary vessel. So they were classified as myocardial injury. At this time, the policy of thrombolysis for everybody was questioned by almost everyone. And subsequently, the Italian experience from the city of Lombardy came on May 8, where experience from all hospitals in the Lombardy town doing primary angioplasty was combined, and 28 cases of ST elevation myocardial infarction were compiled. All of them, though not tested for COVID immediately on presentation, but subsequently were confirmed cases of COVID-19. The default strategy chosen by these hospitals was primary PCI, and again, in 40% of the patients, no culprit lesion could be detected. Now, the CSI guidelines for management of myocardial infarction during COVID-19 were discussed on a webinar where all present and past presidents of the Cardiology Society of India participated. And you all know about it now that 3 groups were, made. And again, the confirmed COVID case is only possible if the patient is already in a COVID-19 facility, is tested, and then gets a myocardial infarction. So for our scenario, this was not possible. Suspected COVID-19 was based on respiratory symptoms of cough, fever, difficulty in breathing, etc., etc. And those who did not have any of these and had low score based on the kind of scale that we had made, that was a low clinical probability or a confirmed non-COVID-19 case. And then they recommended that these patients can actually be taken for primary angioplasty and not necessarily kept in a separate facility, because these were early days and the exact behavior of this disease was not entirely known in terms of its ability to cause myocardial infarction. Not that that is a doubted ability, but how many percentage of patients with actual acute myocardial infarction will actually turn out to be COVID-19. So the policy was thrombolysis for A and B, and then group C, you can choose either do thrombolysis or do PCI. Now, looking at the COVID case scenario in New Delhi, this is the number of new cases that were added, and I have got data up to 22nd of May, which is day before yesterday. Up to 15th of March, we had only 107 patients in New Delhi. And between 16th and 31st March, which is 2 weeks, 113 cases were added. But in the next week, from 1st April to 7th April, this number, 456 new cases were added. So the cases actually started increasing, and subsequently exponential increase was seen between 8th April and 30th April, 3 weeks, and we had 2,839 new cases. And the next 3 weeks in May, we have now seen 8,804 cases being added. So till 22nd May, we had total of 12,319 cases in Delhi. That means that it is now that we are having an exponential increase in the number, despite the fact that there was a lockdown which was put into place from 25th March, as you all know. But it is only after the relaxation has come up and the people have started moving, a lot within the country, that you are seeing this kind of a surge. Anyway, this is our total experience. We have compiled our experience from 16th of March till 21st of May. Our OPD completely plummeted on the 18th of March, and the lockdown was imposed on 25th of March, as I said before. During this period, we have treated a total of 72 patients. The number of patients certainly became much less than what we were usually seeing, as there were no emergency visits and virtually no OPD visits. Out of these 72, 35 were STEMI and 37 patients were non-STEMI, and these are their demographics: 56 males, the age range between 38 and 91 years with an average of 62, 57% of the patients had diabetes, 67% had hypertension, small percentage with CKD, and almost 70% were smokers. Troponin positive, all of them were troponin positive, and diagnosis was made only on the basis of this, plus the clinical criteria and the electrocardiographic changes that were observed. And mind you, none of these cases just has a borderline increase in the troponin, like our upper limit of normal is 0.014 for troponin T. This is everybody here had troponin of more than 0.2. Now, our policy for testing for COVID-19 actually has evolved as we have learned with our experience with the disease. In the initial phase of management, we had no access to testing. We had to refer the patients to RML hospital or any other facility which was close by. But by and large, most of the testing at that time by government guidelines was based on patients' travel history, a history of contact with somebody who has suffered from disease, and so on. And most of our patients were actually turned down from there without testing. So we had to refer them elsewhere without admitting them. But that does not mean that we did not actually admit patients who came with acute myocardial infarction. In fact, in this entire experience, we have only one patient who came with ST elevation and a florid pneumonia that we had to send to a COVID-19 facility. And that also happened before 25th of March. On 25th of March, the private labs actually started functioning and doing the COVID testing. So initially, based on the CSI guidelines, our own personal experiences, and our past experiences with the myocardial infarctions related to influenza and bacterial pneumonias, we started testing based on clinical suspicion only. From 8th of April, we started testing all myocardial infarctions, STEMI and non-STEMI. And from 8th of May, as cases have increased, we have now started testing all admissions with whatever disease they are coming to get a hang of what is going on in the community. It's not that the admissions have terribly increased. The admissions continue to be extremely low. But this is, I'm talking about those who come without myocardial infarction. Some of the patients come for dialysis and for some other ailments as well. Now, the age-wise distribution of our patients is as shown here. We have between 31 and 50 years, 10 patients, but large majority of our patients are between 51 and 70, 64%. 64% of the patients, and a good 22% are actually more than 71 years of age. This is the way our patients presented. 77% presented with chest pain, 23% with dyspnea, epigastric discomfort 4.1, palpitations, and then the other giddiness, etc. And I thought this analysis is very important, and right from the beginning, we were keenly noting down each and every symptom of the patient as they arrived in the emergency and were admitted in the hospital, just to understand how this disease is presenting. Fever was present only in 5.5%. And I want to repeat here that even though people came with fever and some respiratory infection type of symptoms, if there was a suspicion for cardiac disease or myocardial infarction, they were not turned down or referred elsewhere. Symptoms of upper respiratory tract infection were present only in about 5%, and none of our patients who had confirmed myocardial infarction actually presented with a dry cough. Now, we actually placed an X-ray machine right in the emergency so that emergency X-rays can be performed on arrival, and our pulmonology critical care team was available round the clock for scrutinizing all these X-rays. We had 2 consultants who were very, very kind to participate in this program, and the casualty medical officer and the senior resident on duty in cardiology were advised to beam by WhatsApp the X-ray pictures of all the patients before admitting them. Subsequently, the X-rays were seen by the radiologists and ourselves, and these are the kind of findings that we found. Pulmonary venous hypertension in 17. We did find localized haziness in some patients, almost a quarter of them. Pleural effusions, though small, in a small percentage, and in 34% of the patients, the X-rays were completely normal. Now, this is a prototype, one example of a patient. We have several examples like this, slightly milder and different types of presentations in the X-ray. Now, this is the way the patients were managed. Majority were admitted, though not all of them, in separate cardiac ICU, which we created on the ground floor of the hospital, and PPE kits were provided to the staff. Now, of the STEMI, which is 35, primary angioplasty was performed in 28, and PCI after thrombolysis, which actually gives us 1 or 2 days time, during which it is easy to get a report on the COVID testing of these patients. 3 of these patients were actually referred to us after having received thrombolysis in another hospital, and 4 of them we gave thrombolysis in our own hospital because of high index of suspicion, clinical suspicion for a COVID-19 case. In the non-STEMI group, we had 37 patients and 14 of them were treated with PCI. 4 of them were referred for CABG. 19 were treated medically, either because in 5 or 6 of them, the coronary arteries were found to be normal or non-obstructive. Some patients did have multivessel disease, but they refused further treatment. And some, we had only 2 deaths during this period. And all these patients were subjected to the COVID testing, and COVID was found positive only in 2 of the entire group that we have treated. Now, we also had miscellaneous interesting cases during the same time, and we had 4 patients who came with typical symptoms suggestive of viral myocarditis, again with very high levels of troponin, and one of them had fulminant myocarditis with hemodynamic compromise that required a support of intra-aortic balloon pump, extensive inotrope use, intravenous steroid administration, along with supportive therapy to come out of it. This patient had pre-existing coronary artery disease, and subsequent angiogram performed before his discharge showed that he had no new coronary lesions to explain a sudden fall in blood pressure and fulminant heart failure. We had 1 patient with myopericarditis. One other interesting young lady that we discharged only a couple of days ago was a 42-year-old diabetic obese woman who presented with a history of chest pain and a wide QRS complete heart block. She was given a temporary pacemaker. The next day, returned into sinus rhythm with a right bundle branch block, and another day later came into sinus rhythm with a narrow QRS complex, and her angiogram was performed, and that did not show evidence of any coronary obstruction. The echocardiogram performed after the COVID test was negative showed regional wall motion abnormality in the anterior wall. No, I'm sorry, it was in the inferior wall, because the ECG during sinus rhythm also showed symmetrical T wave inversions in inferior leads and a small Q wave there. And in 2 out of these 4 patients, myocarditis was confirmed by cardiac MRI, including this last patient that I'm talking about, who came with complete heart block, who also had evidence of some pericardial inflammation on the MRI and small little pleural effusions on both sides. 1 patient could not actually hold his breath in the machine because of claustrophobia, and 1 patient refused to undergo MRI. And interestingly, again, COVID was negative in all these patients. So this was our experience of the COVID patients. COVID, in conclusion, I have just put a few important points. COVID-19 pandemic has been a unique experience of apprehension, uncertainty, followed by gradual reconciliation with life. A robust screening policy ensured that the deserving patients were not denied treatment. Majority of the myocardial infarctions, STEMI and non-STEMI, tested negative for COVID after thorough clinical screening. Only 1 STEMI with pneumonia on X-ray was referred to a government COVID facility in late March. The second positive case actually refused to consent for PCI. His angiogram was performed, and he was a patient with anterior wall myocardial infarction who refused for PCI, and he was a COVID positive case. In our setup, primary PCI was preferred strategy in STEMI, and we should remember that as cases are surging rapidly, possibility of finding a COVID-19 related myocardial infarction may increase as number of cases escalate. But however, I want to reiterate that a large majority of our patients, including the month of May, have presented with ST elevation or any ST elevation myocardial infarctions, much the same way as we used to see them before, except that our eyes are now more penetrative towards analyzing the X-rays more carefully, and yet we have not found evidence of positive COVID. And that should be a reassuring experience, because the scare in the mind of the people is so much that I'm sure a lot of these people are being denied treatment. Thank you very much for your kind attention.
Thank you, Dr. Sethi, for giving us insight about the real-time scenario in a busy Delhi hospital. Actually, similar was the experience at our hospital, Fortis Escorts Heart Institute. The inpatients have and OPDs have drastically reduced, and the trickling of MIs have occurred. And we did not change our policy. The way we were treating earlier, the same way we were treating. What is your one message, Dr. Sethi, because the numbers are increasing now?
Absolutely. See, the problem is that those who present with typical history of chest pain, and I've gone through all the publications looking for that particular evidence. The two series that I read in the New England Journal, and although the number of cases is very small, and I admit that, and the Chinese series, all had respiratory, majority of them had respiratory symptoms or fever or something else. Majority came to the hospital with chest pain, typical of a coronary occlusion and STEMI. A third of the patients, reported in these articles actually got the MI while they were admitted in the hospital with a COVID already, generally within 7 to 8 days after they were admitted in the hospital. However, there are a couple of patients that we have seen here who had no history of fever, no respiratory infection, no nothing. But still, having said that, we are going to find these patients now that we have community spread. Whether or not COVID is etiologically related to causing infarctions in these patients, or they are asymptomatic carriers that have acquired the disease in the community and then have suffered an acute MI, is very difficult to say. So one has to make a choice between how to manage this patient when the patient presents to the emergency. And as of today, our clinical screening protocol has helped us, but somewhere down the line, we will get a surprise, as we have seen the surprise. So we are testing all our patients. We are treating them with PPE kits on. We are taking all precautions. We have a separate ICU for them. And then we send the test the next day. And I hope that the facilities for testing improve and more labs are given. That the labs are completely overwhelmed and they just cannot provide us with the report in a short period of time. Thank you.
Thank you, Dr. Sethi, and your emphasis on keeping the morale of the healthcare workers high was also commendable. As an owner of the hospital, that is what challenges what we face, because there is a lot of fear among the healthcare workers. So thank you very much, Dr. Sethi. Let's go to the last presenter, Dr. Rajinder, who is coming from Coimbatore.
People, please excuse me. I have another commitment, as I said, and I'd like to take your leave. Thank you very much, and goodbye, and happy treatment for Corona. Be safe and protect yourself.
Thank you, Dr. Sethi. Yeah,
Good
Dr.
afternoon.
Rajendra. Yeah, please.
Yeah, good afternoon, sir. So just so far, we had an exercise that now is community spread is there, and almost 2 months lockdown, and we don't know when the pandemic is going to over. So I think the intermediate or low risk cases with symptomatic, even after medical management, they are symptomatic. Shall we start the elective PCI? That is the question. So now we are all started doing it, particularly the symptomatic. One of my patients is a 65 years old male presented with unstable angina, normotensive, non-diabetic, ECG, non-specific changes. And the RCA shows there is a tight mid-RCA lesion which was stented. And it is found to be the COVID negative. So what we'll do is the elective patients, we will admit in the isolation ward, do the COVID screening, And if it is negative, green zone, if it is a positive in the red zone, and we will take all precautions. We consider every patient is the, even though it is negative, sometimes we suspect and take all precautions. And one of my second patients also is unstable angina, diabetic and hypertensive. And we have done similar, that is the tight lesion in the mid-RCA, then the stenting done. So that is the thing is, it is a time now to start the elective procedures, particularly those are intermediate low risk categories with COVID testing, and then categorizing them green and red zone, and also take all precautions and preventive protocol. Thank you, sir.
So thank you, Dr. Rajendran. That was very quick, and it was a very, very exhaustive session. We have learned the theoretical aspects, the guidelines, and then we have shared lots of cases in the real life scenario. So final word from Dr. Kastrati. So what is your final message? Because in India, we are on an ascending limb. In Germany, you have reached a plateau or maybe declining, but in India, we are now rapidly increasing in numbers. So what is your final take-home point for cardiologists? There is a lot of fear among us about contracting corona. So what is your final take?
So we have been dealing with this problem since 2-3 months now. And in our experience, we never had problems with the personnel taking care of the patients, even for those having already a confirmed COVID infection. So my message is, patients with acute coronary syndromes, they need the same treatment that they had before the COVID-19 pandemic. There is no evidence that we should treat them in another way now. So this is the main message. This is the main lesson we have learned this time. But on the other side, we should take all the measures to protect the personnel in order, so this is our main job in the cath lab, to protect our personnel there from the pandemic.
Gajendra, your last comment? Unmute.
I think we have already discussed all the aspects regarding ACS and stable cases. I just want just one opinion. We have done the primary PCR in many patients. Few patients doesn't give consent of COVID testing. So how we can take the consent from them that they are not willing for the testing, because we have faced such cases also.
Yeah, so we cannot force these patients if they are not giving. So we have to take a full PPE precautions and do the primary PCI.
Even after primary PCI. After primary PCI, when we ask them to go for the testing, they are refusing, many patients. Not many patients, just
we cannot force them for that.
Yeah.
Dr. Tabit Ahmed, any last parting comment? Unmute yourself.
Yeah, thank you, sir. But yeah, as we are going into community transmission, the number of cases is only going to increase. So let's hope that we do as protective measures as possible, and also do what we do usually normally in the cath labs.
Dr. Pawan, your last thoughts? Dr. Pawan? Unmute.
Yeah, thank you, Dr. Nishit, and it was nice seeing you as virtually, though not in person. And thanks, Dr. Adnan and all chairpersons. It was a wonderful session, and hopefully let us come out of it in good health.
We should stay positive. And Dr. Adnan, it was very nice of you to stay all through 3 days with us. And God willing, we'll be coming to German Heart Center in near future to learn new techniques and your ISAR trial series. So, ladies and gentlemen, it has been a very, very thorough, exhaustive 3 days of learning from each other, learning from cases, and all those who could not attend some sessions, all these sessions will be available online for later viewing. The link will be shared with you. You can see at your leisure and learn from the cases, learn from the experiences. And I must thank the Translumina team, the support team, for though there were some technical glitches This was a new web platform. So I must thank, and stay safe, everybody. Thank you very much. Thank you, Dr. Anand. Thank you.
Thanks.
Thank you.